First of all, Dr. Ben will remember Ato Porozwa, an elderly king during our initial phase of the scheme. We invited all the traditional rulers over Delta State for a discussion. And one of them, very old, said, Doctor, called both of us and said, kindly ensure that a doctor for the first time visit my community. And if that happens, I will die a happy man. And so Dr. Ben and I ensured that we put a health facility, functional one, in Oporozwa, or Opogubo. And we were circumcising men, not children, men. 20 years old man coming for circumcision for the first time in such areas. Women are delivered and they have to stay in a native doctor's home for 10 days before he can come out, and they come out with children with meningitis and other sort of illnesses. And so it's a very good thing. Financing, right now that is being worked out. And the government is very key. Delta State government is very key about access to finance. They've actually asked us to continue with it and ensure that it's running smoothly. Funding is being provided, and I can promise Onya and all of you that are with us, very soon in the next few weeks, your funding will be taken care of. And we will ensure that the scheme runs very smoothly. Thank you.
That's music to our ears. So I'm going to give every panelist 30 seconds. Okay, Abby? Oh, questions from the audience. Yes, please. Question, Dr. Shegun. One question. I'll take just two because I'm worried about time. Dr. Shegun.
He also had a question.
Okay, I can continue. Okay, great. Oh, yeah, okay. If you have your hand up for a question. Yes, please.
The gentleman
yes.
in front of the boat.
Okay, thank you. My name is Chinese. A question for Dr. Onya. So you're wanting to pull out. Why?
Oh, you didn't get that bit. Okay.
Okay. Good afternoon, everybody. I'm Dr. Shegun Biton. And I'm also proud to say that we are part of the Access to Finance in Delta. And in Ovade Ward 2, we eradicated maternal mortality. Wow. 5,000 deliveries, 5,000 deliveries, not a single death. So in that area now, maternal mortality is history. So I want to lend my voice that I don't see any better model to improve healthcare. Outreach put in 13 million naira to revitalize the center. It was over the top. If we do it now, we won't spend that kind of money. But the life sales make it justifiable. Now, moving forward, we're all in the same boat. If I dare to strike the nail on the head, like 8 months down the line now, things have not been as it should be. And the question is, what is the sustainability plan? The government needs to balance its books. On the private sector, as much as we are talking impact, if you don't pay somebody a salary and you are talking impact, it is not going to be a funny discussion. So my statement is both a question and a recommendation, and which is that efforts should be made at aggregating some of these projects. Many of us have one center, 2, 3, makes it difficult to sustainably run the bit. So, but if we look at ways of aggregating, have 2, 3, 4 people managing a large subset, it might help with resource allocation, with economies of scale, and with all the other business strategies that can make projects like this sustainable. Will the Commission look at strategies like that? Thank you.
Thank you. So,
excuse me, I have 2 questions from the online, the virtual attendees. One of them is, what are the plans for SRHR HR under SWAP? And the second question here is, what are the determinants to partner with Argon to ensure service delivery to these PHCs?
So I think a question went for Dr. Onya, Dr. Apofeta, and Dr. Ben. I think for SRHR, that's sexual health and rights. And that will go to probably Dr. for now, before we continue with the next set. So Dr. Onya.
The question to me was, why did I want to pull out? One of the reasons Segun had alluded to, and there's no point repeating it. You know, I made some little notes coming here, and I said key success factors for this kind of partnership is, one, there must be a clarity of roles and functions. I don't think that was very clearly defined. Secondly, the vision must be shared. There must be will of action, and above all, utmost good faith. It was absent. It wasn't always present, let me put it that way. And then again, because these places are difficult to reach, because of security issues, the truth was, a lot of the time, the people were running on their own. So we only got electronic reports of what was going on. Even there, maybe because of this lack of clarity, as far as they were concerned, it's government hospital. So the same way, all apologies to my colleagues in the public sector, but they were trying to run like a government, public sector, so, money being paid directly into people's accounts rather than the accounts of the hospital. I will tell the truth that this year was the first time that we've been able to use resources generated from the health center to cover the requirements, their costs. We were what's the word now? Subsidizing it from Lagos for the first 4 years. Salaries, drugs, lab reagents were being subsidized from Lagos for the first 4 years. It's this year for the first time that we're able to cover the costs. So profits, like Dr. Ogbe said, it's something that it's in the remote future. However, we need to be at least sustainable. So that good faith from the employees in the health centers, from Delta states, and then of course with the private practitioners. I think that's the answer to my question.
Maybe I'll also mention for us, initially when the program started as SFH, when we're running, we actually have four actually in the scheme. The challenge we had was initially it started as a program that was for the elderly, women who were pregnant and children under 5. And then of course, in the villages, there are a lot of elderly people, and the government was to pay capitation. So you've already done your business case, and you have a certain catchment number of people to cater for, and the government would pay for those people. But later on, the government came back and said, oh, we cannot cover the elderly, who are the ones who are mainly in the villages, and just pregnant women and children under 5, I think using BHCPF. And so for that, our whole business case went into the mud. That was the end of it. And I think one thing about the private sector is you really need decisioning on exactly how, like she says, not just good faith, but understanding roles and responsibilities. And so for us, that was one of the reasons why this year, actually, our chief finance officer said it's hard enough. You've lost money all these 4 years, like she says, and so let's just pull out. But of course, we're back to square one. We really want to support the scheme, and so I'm still in the persuasive mode with my MD and the chief finance officer that this can work if we put our heart into it. So I think that's probably that question. So Dr. Apofeta, over to you.
Yeah, thank you very much. I must say that the private sector spirit, pure private sector, then pure public sector, and then the mixture of it with public-private partnership is a bit very delicate. Like I said, I'm purely a private sector person until 8 years ago. when I got into government and government as a consultant in the health system. So decisions are made, are changed, are remade in public sector very delicately. As government changes, as system changes, finances changes, a lot of things changes. But luckily for us in Delta, government has been consistent and have been directional. Secondly, funding in Delta have not been too much of a problem. But what happened in the last between 2023 and now is systemic change, a transition from old to the new. And some months were lost in the process of transition. But luckily, like I said earlier on, I've come on stage. I'm looking at everything. I showed a table, an Excel table to Onya earlier on today, where we have taken pain to study every of the facility, the 18 facilities running the access to finance in Delta State. And we've come out with a financial model to see how it can work. Luckily for me, the new board, the board chairman and the member of the board, majority of them are old and new, are very interested in access to finance. So pulling it up won't be a problem. Regarding aspect of it where some release, that is the elderly, are chunked off, that will be looked into in due course. In fact, there will be a policy change very soon, and I'm sure it will enable the system to run very well. But I must thank all of you. I'm a private sector person. And I know how it looks like in private sector when your fund is not coming as and when due. But I can promise you that will change henceforth with my regime and with it going forward. And I'm sure more people will emulate the Delta model as soon as possible. More so when my former DG is now consulting at that national level, and he will also bring fund in. Thank you very much.
Dr. Ben, I can see a lot is actually resting on your shoulders with Algon, but I know you have excellent support with Dr. Chris, former chairman of CARU, LGA, to help to keep you on track. Sir, am I right on that? Yeah. You very well, excellent. So Dr. Ben and then Dr. Ogbe. Dr. Ben, you had a question.
Yes. First of all, Akala and I work as a team, so and we're always together, so it's a good team. In terms of the modalities for private sector engagement with Algon, it's definitely not going to be a one-size-fits-all. We're going to compartmentalize it and see what's most suitable in the various dynamic areas. But the important thing is that it's still going to be in line with the SWAP and the national policies to ensure that there's one report, one plan, and all that. Thank you.
Yes, thank you very much. I think the question was around ensuring access to sexual and reproductive health services. I think there's a wide spectrum of conditions under the SRH platform, and I think a lot of this are already happening under the RAMCA, which is reproductive, child, maternal, newborn, adolescent nutrition services. But we are refocusing to say there's a need to actually focus and expand on some of these services, particularly around post-abortive care and more of those other sensitive parts, and that's going to happen. So even with the Basic Care Provision Fund that we're just now revamping with the reforms that is happening sector-wide, that is being emphasized in terms of both ensuring that these services are covered to a large extent by the health insurance scheme. Literally all the components are now going to be covered in terms of benefit package. And for the part of like the National Primary Care Development Agency, in terms of doing revitalization of primary health care, is one of the things we're really focusing on, both in terms of the capacity of the health workers. It's part of the modules which they are doing the refresher courses on, so that they can provide those services. And also, it's just part of what we expect to happen when we do the revitalization. And I just want to seize the opportunity to add that the Basic Care Provision Fund, what is doing, even you can see some of the examples in Delta, is that it's actually what is creating the platform on the medium term that will enable more private sector involvement, particularly at the primary care level. facilities are learning how that they can receive money and manage money on their own. We are now doing a lot of revitalization that by late this year, early next year, more and more facilities will do, and working with the private sector because they are also doing a lot of revitalization, and they are making a lot of tremendous effort, particularly Pishan, to see how they are aligned and integrated with us to do it together. So that platform is already being created, and there's just that mindset shift, like I said, from purely from profit to what Dr. Anna is doing, finding that middle ground, and then also seeing that we have the right governance structure and the regulations, just like you said, that spells out rules, responsibility, and rights of everybody to see that this happens. So this is really where the conversation should be going to in the coming weeks and months. Thank you very much.
Thank you very much, Dr. Ogbe. I think one thing I think that came out quite strongly is the important role of a framework of some sort. And I think the whole role of the National Council on Health, for example, is to kind of like give fillip to these sort of frameworks. And I'm assuming Algon is going to be in the, they're going to be there at the National Council on Health, because you probably like a framework by which you can engage with the private sector. But I'm going to take this question to Pishan and say, I know you select facilities, primary healthcare facilities to work with. How do you do it? Do people just come and say, I like the one in my village? How does it go? How does it work?
Thanks. So one of the biggest projects in Pishan, the Private Sector Health Alliance of Nigeria, is the Adopt a Health Facility Project, where we're adopting 774 primary healthcare centers across Nigeria, one in every local government. And this has brought to the fore the need for partnership across all levels. One of our strongest partnerships is with the National Primary Healthcare Development Agency, where we're working to ensure that we're not duplicating efforts. We're working through the framework that exists currently. We also have a lot of collaboration with the Basic Healthcare Provision Fund.
You're welcome. I think maybe I think we'll just close our panel quickly, but finish, because I can see that the minister has arrived, and I know you have 1 hour, sir. But let's go on. Go on.
So working with the different agencies of government at the various levels to ensure that everybody is carried along. In terms of facility selection, there is a lot of collaboration, I said, across these different spheres of government. And then there is the burden of disease. There is also the catchment area, depending on where we're working. So we have a lot of inputs from stakeholders. We also do a lot of community analysis, community assessment during the facility selection process. So there is a lot of conversation that happens before we decide finally on the kind of facility that we're going to invest in.
Thank you very much. So if you notice, the Honorable Minister of Health and Social Welfare for the state has arrived. We will quickly be rounding up our panel because his panel is coming up immediately. I know he has a limited time, but I'm going to give each of you 30 seconds to commit to something you're going to do as a result. 30 seconds to commit to something, starting, of course, with Dr. Ben.
Thank you very much. All I'll say is that Argon is ready for business to deliver quality primary healthcare services at the bottom of the pyramid through sector-wide collaboration and partnerships. Thank you.
And HFN is coming to visit you very soon. Okay.
Okay, and just to say that the private sector is ready, willing to support government at all levels to improve healthcare indices for Nigeria. And so we're ready as long as we're invited to the table. We're happy to be part of the conversation.
Thank you very much. And I think the minister committed to finding a way of the private sector getting involved.
I think I can safely afford to commit on behalf of my boss, Dr. Muya. I know that it will revitalize primary healthcare centers over the next 3 years to hit the target of at least 7,000 functional plus primary healthcare centers, expand BACPF funding to them, and somewhere along the line see to it that private sector is involved in this and running some of these centers. Thank you.
Thank you very much.
Yeah, I've just in a nutshell that we are ready in Delta to continue with access to finance, and we are ready to finance it. Thank you very much.
And Antonia, last but not the least.
To say I was in the valley of decision before I came here.
She's going to commit to go
because,
back.
yeah, because our 5-year contract expired in September. I will renew my contract.
Yay! So thank you very much. A really warm thank you to all our panelists for coming. It's been a wonderful time. For the minister to know, we have panelists from representative, the advisor to Algon. We also have Pishan. We have, of course, the National Primary Healthcare Development Agency. We have the Delta State Contributory Health Scheme. And we have Pelion Hospital, which is one of the foremost providers of public-private partnerships in the country. Yes, on the Delta scheme. Thank you very much, sir.
We'd like to take pictures before
yes,
you leave.
Please, definitely.
May I invite the key sponsors of this program to please join in this picture. Dr. Pamela, please. Do you want to come up? The key sponsors, please come up. We have Farm Access. We have Informal Markets. Results for Development, please come up. Nigeria Health Watch. JNCI. Iwosan Investments Limited. Please come and join the picture. Just a second, please. Tanit Medical Engineering. Healthy Entrepreneurs. I will join. And then Digital Transformation for Health Lab. Iwosan. Okay, please hold on. Thank you so much. It's a big round of applause to this panel. They've done the topic. They've treated it very well. Thank you so much. Okay. Dr. Jennifer, thank you so much for moderating excellently. We still have a full room. This is amazing. I guess everybody please clap for yourselves. This is amazing. As I had mentioned earlier, we will be pivoting to the panel that is led by the Honorable Minister of State for Health and Social Welfare, Dr. Tunji Alausa. He will be giving us a keynote on accelerating the adoption of digital health and effective use of generated data to improve the health system. Ladies and gentlemen, it is rare to have two ministers for one ministry at an event. So you can imagine that the ministers have taken this dialogue very seriously. Dear sir, thank you so much. We welcome you all. Please, a big round of applause. Okay.
I'll sit. Can you? Okay. It's
Thank
more
you.
of talking to what we've done at the Ministry of Health on how there'll be two flavor to this. What we've done in terms of the digitalization effort of the government and how the private sector can key into what we're doing. As everyone will recall, when we came in as a government, we came up with 4 pillars on how we're setting out to reform and revolutionize our healthcare system based on the mandate of the President Bola Ahmed Tinubu. The first pillar, improving governance. Second pillar, improving our population health outcomes. The third pillar, unlocking the value chain of our healthcare system so that our healthcare system can begin to be a contributor to our GDP as opposed to what we have now, mostly being a cost center to our GDP. And of course, the fourth pillar, looking ahead beyond physical security, but also as part of our social security and national security. With all this, we have a digitalization effort as a cross enabler of this fourth pillar. Now, we are all aware of the indicators that we have, the very unenviable position we're in the world as having one of the worst maternal mortality rate in the world. Bad eye on the 5 mortality, infant mortality, severe malnutrition. We get all this data, but these are data that really are data that anybody can swear that they are well validated. And all these data are gotten from multiple sources, piecemeal. Our development partners have helped us, no doubt, but the way things have been, one development partner will go to Lagos and say, oh, I'm helping you set up an AHL. Another development partner will go to Borno, we're doing this. But one thing is constant here. We're a population of 220 million people, 36 states of the Federation with FCT. So, and no one is talking to one another. We have all these disparate programs, interventions all across the country. We're collecting all this data in multiple different ways, multiple formats in 21st century. How do we now begin to reconcile this? And that's why we said, without starting a national digitalization effort to bring everybody together, we cannot make progress. Because we all know of evidence-based. Evidence-based is being used in everything. Medicine, policy, education. So that's why we, as a government, we've taken this digitalization effort and put it on the forerunner. I'm leading that effort. So we now have the Nigeria Digital in Health initiative, which we started off by setting up 20-man team to marshal this Nigeria Digital in Health initiative. So what's this all about? It's about rebuilding a digital health architecture in terms of in areas of governance, security, services, and data storage. So how do we intend, or how are we working to moving this process all along? Now, and I'll tell you where we are today. We've made tremendous progress, but I'll fast forward to where we started from and how we had planned and we're planning and moving forward to do this. We're starting out with the lowest hanging fruit to build up a national electronic medical platform where every life that gets on that platform will have a unique identifier. And that unique identifier will be a national identification number. And we're not oblivious of the fact that not everyone will have a unique will have their NIN today. The people that don't have NIN will have a TNIN, which will be a temporary national identification number that will be computer auto-generated. And as that person gets their real NIN, that replaces the TNIN. So every person that gets in there, so we'll have this unique identifier. Fast forward 2 years from now, we might have 90 million people on that platform. And what we've also done, we're also collaborating with NIPSI. We've designed a short demographic interface with them, where every newborn anyone that gets NIN gets automatically enrolled in that platform. And as people live and die, they get the people that have died will be archived up off that platform. So at any point in time, we have clean source of data. Now, we're starting the pilot now. We will have a federal tertiary hospital, geofence with a primary health care center. So say, for example, Lut, every single primary health care center around Lut will be geofenced into the same platform with Lut, so that if a patient goes to a PAC in Idiaraba or somewhere in Surulere, the data will flow, there will be bi-directional flow of data that will flow to the tertiary center. So 2 weeks later, if a physician or a provider is seeing that same patient in Lut, they already knew that the patient was seen somewhere in Surulere 2 weeks ago. So there will be more continuum of care. And into the future, as we build, I'll talk about how the data will flow. So that data set will now flow from every tertiary hospital, every PAC, into a primary data storage center that we will own as the federal government. As we build this platform, it will have a huge interoperable connection where states will plug in, and into the future, the private sector can plug in. As they now plug into that, there will be another parallel data flow to a bigger secondary data center. As a government, what we want is that we just want to own the data so that we can begin to use this data, analyze, aggregate, and disaggregate for policy making, to look at outcomes, look at interventions, so that we can begin to make more evidence-based decisions, design evidence-based policies. Now, at the end of it all, we want to build a big, robust digital health business for the country. The government is not going to own any of this digital solution. We're using the power as government, as an enabler to set this thing up. Once it gets set up, it will be the private sector that is driving this. And that's where the private sector will key in. And I'll tell you how this will be significantly monetized into the future. But I'll go back to the operationalization of the platform first. So as this data flow, if you see now we're collecting data at the PAC level, going to the tertiary level. So we're now talking to the states that as they go through their own digitization effort, they should use one solution, one EMR solution company, so that they can just plug in. It'll be easier for them to plug in. But some states, if they decide to use many more technologies, EMR company, solution company is still okay, they can plug in. So as the state plug in into this, we now begin to have data from a PAC level, federal tertiary level, and the secondary level. And into the future as well, we would like the private sector to plug in. On the front end, we're currently collecting a lot of public health data that today, if you look at the questionnaire that's been used, there are like 500 question points on those questionnaire. Those get manually fed into system at the world level, local government level. Nobody's validating, cross-checking this. If you have somebody that is manually completing that data, if they make a mistake, it just flows to the DHS2. So it's not the way, the data we have now, those data are not clean. On the frontal level, we would deploy another public health guardian data that, about immunization, about maternal, about the journey of any woman during their pregnancy. So say a woman goes to the community level today, get seen at their physician, I'm pregnant. We'll get all those information, it will flow through. A patient that presents at the PACs, how many patients are you? Do we have RDT? Do we have any blood smear? What medication? have been given to treat that malaria. Somebody that has that got vaccinated, where are they in their program of vaccination? So all those can easily now flow. We can now begin to have all those data flow across from the community level, PAC level, straight into our primary data center, where at that back end, today we have some data on the DHIS2, which is an open source software that they've promised us that it will work. But even if it doesn't work, we're going to create our own primary data center, where we can now look at our data, analyze, aggregate, and disaggregate, and see where we're at exactly. Doing all this, we're not going to use any foreign technology solution companies. Every single company that we will use, that the government will engage in, will be local technology solution company. That, we know that. So at this point now, we now have RFI that we request for information from all technology solution companies in the country. They're free to apply. They can go to our website, put all the data sets. What we are going to do, we know a lot of people are capable. They have capacity to run AHR, their AHR works. They have the best solution. But we cannot continue what we're doing now. What we're doing now is that all these solution companies are just trying to feast on one another. One will survive, another one will not survive. Today, somebody knows the governor of Kebbi State. They go talk to the governor of Kebbi State. Governor, oh, cool. Kebbi State is going to use your solution company. After 8 years, another governor is getting there. Somebody goes talk to that person. They just cancel this company. So the current environment we have now, they can't grow. So what we've now decided to do is to create an enabling environment where every single company will thrive. I would be very honest to tell you, in the initial part, we're really looking to get in about 6, 7 solution companies that will go through rigorous pre-qualification process, data-driven, objective, in an objective manner. I will not be influencing it, and no member of the committee will be influencing it. The grading and scoring system will be done in a computer base after the evaluation of all of these solution companies. And the way we've done it is that we've also done mapping around the country so that each of these solution companies will have enough volume at the outset. Now, we know about 6, 7, 8 people will be the eventual winner. But that's not where we're stopping. In fact, that's just a small piece of the business. By the time we're done, we will now have so many plug-in where secondary tech company can now develop multiple platforms to plug into this system. Care coordination module, pharmacy module, name it, mental health module. At that point, federal government would have stepped aside. It would now be driven 100% by the private sector. What we want to own is the data. The tech companies will now be able to monetize by charging their licensing fee, other user fee. We'll give them opportunity within the framework of the very detailed data governance structure that we've created to be able to market and use some of the data for money to monetize some of those data. So 3 years from now, 4 years from now, we will now have a flourishing digital health economy beyond what anybody can ever think about, in a way that people can come in. If you have this capability that works, that has been vetted, you will do well. It won't be that because you know the Minister for Health, you know the Minister for Education, that's why you're able to get on. It will be like now merit-driven, capability-driven. And we have a lot of brains in Nigeria that are developing these solutions. We just need to give them opportunity to thrive. So to end and to really answer the question that how does the private sector fit in our digitalization effort? It's not the private sector fitting in. It's we're building this for the private sector to take up and run with it and just blossom with it. So that's my keynote speech. So we can now start the other part of the.
Thank you so much, Honorable Minister. Please, can we give him another round of applause? It can't be like saying our professor wake home class, we no carry chalk. He was just reeling out everything from his head. Thank you so much, sir. Because I remember in March when the committee was launched, that shows a lot of work has gone into designing and conceptualizing the digital health agenda. So we'll go straight into the panel discussions. We have already introduced our main Oga. Then the moderator for this panel will be Dr. Egbe Osifo Dawodu. Please, can we make her welcome?
You want me to come and help you? How are you?
Then the panelists, we have...
I would like you to sit next to me, but by virtue of your work, you have to sit there.
Okay, yeah. All right, then we have, as one of our panelists, who gave a very excellent presentation earlier today on AI. Oga Minister, I wish you were around to hear him, so when he presented. So we welcome Dr. Ricardo Batista Late. And
how are you?
I can see
are you enjoying
we
your
have
stay?
Dr. Nneka Mobison. She's the co-founder and CEO of MDoc. So she's been in the digital health ecosystem for a while. Welcome, ma'am. And then next is Ms. Irene Waokwa, the CEO of Infinity Health Africa. Please, can we welcome her? We also have, as one of the panelists, Dr. Adiolu Arogundade. Then he's the president, Society for Telemedicine and E-Health in Nigeria. Welcome, President. And then finally, but not the least, she will be joining us online. Marie-Lise Gogent, I'm sorry if I didn't pronounce it well, lead digital and AI for human capital at the World Bank. Maybe you can check if, oh great, she's online.
Yeah.
You're welcome. Okay, over to you, ma'am, for the panel discussion.
Oh, no, it was on.
Oh, thank you. Good afternoon, everybody.
Good afternoon.
For people who don't know me, my name is Egbe Osifo Dawodu, and I think this is a very interesting panel to be talking on technology, especially on SWAP. I spent 16 years of my life in the World Bank Group. I left as a manager. And since then, for the last 10 to 12 years, I've been running a partner and advisory services, basically around Africa and the world, but a significant amount of our work is in Nigeria, and we have an office in Nigeria, and obviously of Nigerian origin. So I'm very happy to be here. And on digital transformation, I had asked several people, what questions should we be asking the minister? So I have a whole host of people who have questions that they wanted to pass on. But before we start on the questions, I was going to ask each of the panel to just say in 2 sentences how they got into the digital health or AI or data space. Thank you. So maybe we'll start with Dr. Arogundade.
All right. Good afternoon, everybody. I hope I am audible enough. All right. Hi, much better. So good afternoon once again, everybody. Honorable Mr. Sir. My journey into digital health is a bit long. I started out while I was in secondary school, actually. And I started out studying computer science. But I didn't complete the computer science education, so I hopped into medical school. And of course, after I came out of medical school, I could think of nothing more than digital. And somewhere along the line, I went for my master's in the University of Edinburgh in global digital, e-health actually. And in a couple of sentences, I ended up being the president of Society for Telemedicine and Health in Nigeria. And that's where we are right now. Thank you.
Thank you. Oh, I forgot to tell the panelists I'm a very strict timekeeper. Just because you spoke first, I allowed you to go more than 2 sentences. Dr. Necker.
Thank you. Good afternoon, everyone, Honorable Minister. I am a mechanical engineer, a pediatrician, born to a father who helps to start the first state university of science and technology in Nigeria, who helped to build what we now know to be the World Wide Web in the US, but came back from MIT to actually support building his country. But this country wasn't very kind to him. He had a massive stroke at the age of 52 that ultimately killed him and ended, quite frankly, I think, the transformation that we could have seen in this space in terms of technology years ago. And so because of that, I'm here. I started a digital health company in his name for him and for all the people that have been subject to the failures of our system. But now, we're seeing a new today and a new tomorrow, which is why we're all here.
Thank you. So, Your Excellency, why digital health?
Thank you. Technology and innovation has just been something that excites me all the time. And it's just as a second nature to me and my hobby. In my previous world, before I came in onto this job, I functioned as an executive chairman of my organization and the chief technology officer. So, so it's something that I've done over and over and over in the last 10 years.
Thank you.
Well, can you hear me? No.
Yeah.
No? Can you hear me? Yeah, there you go. Well, good afternoon again. It's a pleasure to be with my colleagues on the panel, Honorable Minister. It was quite inspirational listening to you, and so truly thank you for that. And also greeting Marilise, who's online, who's a good friend, who I'm going to be with in a few days in Berlin at the World Health Summit. So answering your question, just to say that I did my first attempt of programming at the age of 6 because my dad was in IT. And so that's where I got immersed into digital. I became a medical doctor trained in infectious diseases and then always worked in the frontier through academia and my work in the digital front. Then I was elected into parliament for several years. I served 4 terms where I pushed for a lot of legislation in this field. And of course, more recently as CEO of Health AI, the global agency for responsible artificial intelligence in health based in Geneva, working with governments and the WHO towards ensuring the responsible use of AI for health system transformation and ultimately to be able to help transform health systems with the power of technology. And that's my main driver here today. Thank you.
Thank you. And we really loved your presentation earlier. And it was very interesting. I mean, we have technology who can actually talk and have a technology person who's in health. We have 2 politicians on the panel. We're really very blessed.
Good evening, good afternoon, everyone. My name is Irene Ngokwa, and I've spent the last 16 years working in various multinational pharmaceutical companies across sub-Saharan Africa. Moved back to Nigeria a couple of years ago, and started trying to answer the question: now that all the big names we know are leaving, how do we get ourselves, self-sufficient? How do we drive the competence that we need at scale? There's no other way but digital. And over the last 1 year, we spent that time researching, trying to understand key market needs, key barriers, and how to leverage, technology to drive market access at scale.
Okay, thank you very much. Yeah, you would agree with me. We have a very interesting panel with different perspectives. Your Excellency, several of the questions that were raised, you actually had responded in your speech. But just to ask for a bit more detail, one was an issue you raised was this, and you described in great detail the sort of strategy of developing a digital platform and then the different roles of different folks. And there were two issues one wanted to raise. Currently in the country, I mean, at least before your new government or the new government has brought in this new money into healthcare, most of the healthcare funding in the country was from the private sector. Either we were paying for it or a small bit of insurance. And now you're developing a technology platform that does not include the private sector in the basis, where if you look at any of the DHS, any of the data, many people go to the private sector first. So that was, and so the question was, you talked about it, but how will the private sector and the patient sort of be integrated so it's easy for them, you know, in terms of the private sector? And I would cheat for you. The second question is, this digital transformation with primary healthcare facilities and folks in Luth, I went to Great UI, so I'm not going to talk about Luth. But how are these people going to know how to use technology and computers? And they don't teach them in school. The curriculum, as far as I know, hasn't changed. So maybe, Your Excellency, you have some news for us there.
Thank you, Dr. Osifo Daudu. Actually, before we even went, before we inaugurated the implementation committee, I went to several of our hospitals, PHCs, federal medical centers, to see what they have. And I'll just tell you an example of Ebutemeta. I sat through for about 4 hours. The solution company that FFF's Ebutemeta uses now. The CEO came, went through everything. The kind of platform they have is very robust. And I said, oh, this is good, we can just use this. But then, if we use that solution company, we're talking about for the entire country of Nigeria. A company with about 120 staff, still one CEO person. If anything were to happen to him, we jeopardize the entire country. And that's why I said we would do this in a very robust way. Now, the second part of your question that, oh, we're deploying this, and I won't answer the first part. I wanted to start with the second part. We're deploying all this, we will be deploying all this technology platform to PACs. How are they going to use it? We learned from Ebutemeta, when they started, they put all these laptop, everybody was confused. Then, what did he do? He used something that you can actually now use your hand, type, and they'll touch and things. And over a month, weeks over weeks, month over month, people got used to it. They advanced naturally, and they're using all form of platform now. So, and that's the exact thing we're going to replicate at the local level. You use touch base for them. We're very cognizant of the fact that people, not many people can type. We can just use touch base. Those are the kind of solution, those are the kind of hardware we will deploy. And as we set this up, we also know that power, and I was at the meeting, I was at one of the conference, Indili Jide brought a question of how do you, with this inconsistent, so irregularity that we have in energy, how do we manage this? The design of every unit will have solar backup, and the way the data would, during the day, it will be more of intranet for them so that they can have continuous flow of their data. And we'll set it up so that at every, during the night, 12:01, there will be data upload into the cloud to refresh. So we already have that part covered. Now, when you said about we're setting up this thing up without involving the private sector is heavily involved. If you look at the 20-man committee implementation team that we set up, we're very deliberative and very careful in the membership. We chose several subject matter experts there were people that were chosen to represent the private sectors as well. And we have to be careful as we do this, because we want this to be very sustainable 10, 20 years from now. We don't want to bring too many private sector in. People will now say, oh, they're already biased. Because at the end of the day, this platform, all this platform we're building would all be owned and managed by the private sector. But as we design this, as we move forward in doing this, we have the private sector on our mind 100% of the time, because the government is not going to own any part of it. We're using our power, our resources as government to develop this, to enable this. At the end of the all, the only thing we need as a government is the data. We want clean data that people can trust, data that we can validate, and we can use to expansively develop our healthcare system.
So, thank you so much, Your Excellency. I think that answers quite a few of the questions raised. I would like to use this opportunity to, Marilise, are you there? Marilise? Oh, yeah. Hi, sorry, I didn't want to keep going back and forth. So I was going to ask you your 2 sentences, and also given what the minister says, I know that you're working with a new project that's part of the SWAP. So I wanted you to say a bit of how the World Bank is planning to support some of the work that the SWAP with the which the minister spoke about earlier, and the digital transformation with the Minister of State just spoke about now. So if you can please introduce yourself, 2 sentences, how did you get into digital tech? And if you can talk a bit of from the perspective of what the World Bank is doing in this area, drawing on some of your experiences from other countries. Thank you.
Thanks, Dr. Emery. So, like many of the other panelists, I am an engineer who got involved and interested in economics and functional medicine, and for now there's a role at the World Bank to lead efforts on digital and AI for human capital. In response to the question that you've asked, I will say that I think the first absolute essential point to recognize is that fragmentation in the health sector undermines the health and well-being of those it's meant to serve. It is like trying to piece together a shattered mirror. Each fragment reflects a part of the story, but without unity, the full picture is lost, leaving patients vulnerable to gaps in care and mistakes in treatment. In that regard, I really first want to congratulate the government for creating and changing the focus in the health sector from a short-term, donor-driven approach to a long-term, sustainable, sector-wide approach. There are several examples in Africa, from Zambia, where swaps led to better resource use, in Ghana, where the government was able to take much more control of sector planning and reducing dependency on donor-driven agendas, to Rwanda, where the swap led to significant improvements in life expectancy, maternal and child health, to Bangladesh, where swaps encouraged a move away from these short-term fragmented donor-driven projects. We know that swaps work. And now that Nigeria has adopted a swap approach, the World Bank will indeed, through our new investment called the HOPE, which stands for Human Capital for Opportunity, Prosperity and Equity, the HOPE Health and HOPE Gov projects is a series of projects that will support the swap agenda in Nigeria. It will do so by financing several areas to crush maternal mortality, including community-driven service delivery, as well as financing for this digital in-health agenda. And I think it's really essential what the Minister said in his remarks and the plans that the government has for thinking about digital as a core and cross-cutting enabler across all the areas of the SWAP agenda, be it how community services are delivered, how patients are tracked between and complete picture of a patient's health history can be formed regardless of whether they access public or private care. And I will end my comments by saying that we have seen that these approaches and the sector-wide digital enterprise approaches in the health sector creates more opportunity for the private sector. We know that 50% of Nigerians access healthcare through the private sector. So we know that healthcare in Nigeria is a 50-50 partnership between the government and the private sector. We've seen how this enterprise architecture, the sector-wide approaches to digital and data can create new kinds of businesses and enable the entire system to deliver healthcare. So we are a proud supporter of the government's efforts, and through the new financing that was just approved on the 26th of September, we hope to continue to make a contribution in this regard. Thank you.
Thank you so much. I think that's very helpful. Dr. Necker, as a member of the Nigerian private sector, you've heard what His Excellency said. You've heard the World Bank folks talk about money. What do you think? What do you think about this wait for the private sector? How are you getting ready to get engaged?
Thank you so much, Dr. Sifo Dawodu. First of all, let me just talk about the emotional aspect. I'm excited. I'm thrilled. I'm so excited as a member of the private sector to hear what His Excellency has outlined, to hear about the backing of the World Bank. This is what the private sector has wanted all along. If you kind of look at innovation from a technology perspective across the world, it's really critical for government, private sector, and academia to work hand in hand. The US government really helped to fund a lot of the World Wide Web work that my father was supported from a distance in the US. And to see that we have a government that really has that localization factor, understands the value of private sector, is intentionally strategic about creating that platform for us all to integrate, recognizing that's only going to build and build for not just for us, but for our generations to follow us. That's exciting. I co-founded MDoc, which is a virtual self-care health coaching platform. We basically support people that 99% of the time they're out of the healthcare facility. We see ourselves as extending into the community because, again, I look at my dad. If he'd had a health coach to help him in managing his uncontrolled hypertension, he probably would have been alive today. And so we recognize that there's a lot people can do in themselves. But to do that, when we first started 7 years ago, we thought we were co-designing with the people that we serve. We did a survey of 1,000 people. But we soon realized that a lot of mobile phone penetration rates are not appropriate proxies for digital literacy. We saw that people were not digitally literate and therefore couldn't become health literate. And so we had to invest in not just a digital approach, but a phygital approach. We set up what we call nudge hubs, health kiosks in the community, where people could walk in, meet with a coach in person, learn how to onboard onto the digital platform. And as we got to understand them and got to understand the longitudinal aspect of their lives, we started realizing the social determinants of health were affecting them. Financial literacy concerns, nutritional issues. And so we've had to build around that. And we've created this 4-pillar integrated, connected ecosystem approach that will really be able to link with what His Excellency has highlighted. He very clearly said, look, there's going to be opportunities for care coordination. My team was messaging me right then and there when he was speaking, like, let's go, here we are. We see ourselves, we're doing work on mental health. We're helping people really around building that capability, unlocking the agency and empowering them to do what they can in terms of living those healthier lives. And so for us, His Excellency has highlighted, we have a place, we matter, and it's on us right now to work collaboratively with the government to actually ensure that we see a new tomorrow for our country and for our generations to come.
So, thank you, Dr. Mobiseneto. Dr. Raf, what sort of advice, from the regulatory as we think about entering this new world of where we haven't been before, but we have a new tomorrow, and with all this data comes the issues of how do you manage the data, using AI or big data analysis to get to the kind of policy advice that His Excellency talked about. What advice do you have, from other countries, or what other people are thinking about these days?
Well, I want to start by saying that you're not the only excited one in the room. Coming from abroad, I can say that it is not very common to find governments with this mindset and wanting to bring the public and private sector together. And this is something that I think can be transformative for the country of Nigeria, looking into the future. Because ultimately, what are healthcare systems for? They are to serve citizens, they are to serve the patients, and to do 4 key things, or one of 4. If it's a curable disease, we should cure it. If it's a preventable disease, we should prevent it. If you can't cure it or prevent it, you need to manage it. And if you can't manage it and it's an end-of-life disease, you need to make sure that you're providing care and comfort at the end of life. These are the 4 things, essentially, that we should be focusing on. And as I presented earlier, lowering the burden of disease is critical if we want sustainable healthcare systems in the future. What the Honorable Minister said here today is so important, which is it really doesn't matter how we provide the care. We need to do it efficiently, which means that we have to use all of the resources in the country, be it public, be it private, be it social. And data is critical if we want to use the digital technologies, and particularly AI, to make that transformation happen. What is amazing, what made me change my life towards leading now health AI and coming from politics is precisely having advocated for health system transformation for so many years. Now we are at the brink of a new era driven by artificial intelligence that can help all of this vision be transformed into reality. But the thing with artificial intelligence and most digital tools, but AI in particular, is that it's like a rocket, like a space rocket. It's amazing technology, but it will only go to the moon or to Mars now if you have fuel. Data is the fuel that will get there. And it has to be not just any data. It has to be good data, quality data, data that relates to your population. And this is a huge issue. You know, there's that famous wording in digital space, which is garbage in, garbage out. And if we don't have that data, we won't be able to embrace the power of AI for the transformation we're talking about. That's why the model of data collection and distribution of data that the Honorable Minister presented, overcoming the bureaucratic process, not depending on the relationship between a private sector partner and the government, but making sure that this is an accelerator for all of society, the whole philosophy of SWAP, I think that is of critical importance. Moreover, the minister also addressed the issue of monetization. Money, there is a tremendous amount of money behind the data. Data at the scale of a country like Nigeria is a true gold mine for the country, beyond the fact that this data represents sovereign interests. And so harnessing that data in a way that can be used for technological advancement, but it can also be used to make Nigeria a hub for investments, including external investments, to make Nigeria, for example, a hub for clinical trials in the region. And so for us at Health AI, what we do, as I explained, is supporting governments through technical assistance so that countries like Nigeria can build their regulatory capacity to validate AI solutions, to ensure they're safe, they're quality assured, and they're effective before they go into the health system, to build trust towards AI. That includes a very important component of data governance. And so it is important that companies, when presenting their technologies to the regulators to get validated, that they comply with data governance principles in line with the principles of the responsible use of artificial intelligence. And so, you know, having the Honorable Minister next to me, I can make the pitch. That would be great for Health AI and the government of Nigeria to join efforts. Because what I'm hearing here is really the beginning of a very special transformation for the country. And I do believe that we can use artificial intelligence to improve the health outcomes and well-being of the population. Thank you.
Thank you so much, Dr. Ralph. Maybe you'll have, I know that you maybe, because last week was ONGA, and I heard the Minister of ICT sort of publicly say that his goal was to make Nigeria one of the top AI countries in the world. I mean, given the fact we have the population and we will also have very unique sort of set of information. So it's really very exciting to see this in healthcare. And so, Your Excellency, that's a question coming to you. are you working closely with the Minister of Technology, who actually said this openly to a large international thing, that in 10 years, what we've done in fintech, we've just started?
I can tell you, this president came, and I'm going to just 30 seconds. When he was campaigning, President Bola Ahmed Tinubu, when he was campaigning, he told Nigerians, I will be honest with you, when I get in as the president, I will do the right thing. And and we can see it now, what the president is saying, that we need to work as one government, a all of a government approach. And the way things are being done now, we're seeing it all around. Working as a all of government approach, then sustainability. Whatever we do now is not short term. It has to be sustainable into the future. That generation yet to come, when they are born and they look back, they'll be thankful to us. With this digitalization effort, it has to be sustainable. And we're not leaving any stone untouched. We're collaborating with everybody. The Ministry of Information Technology, NICDA, NIPSI, everything. We've had meetings with them. And we, Bosun Tijani and I, are in sync. In fact, I represent him in some other areas as a Minister of Digital Technology. If you were GITEX in Dubai, we just launched Nigeria, GITEX Nigeria, which is going to focus only on AI. And we're working closely now to see how that meeting, that expo will happen early next year. So whatever the Minister for ICT, Digital Innovation is saying, we're completely in sync and we're working together. We don't want, as we do this and move into the future, very carefully, we're piecing everything together, getting everybody on board. This is what we're doing. Do we need to do something else at this? Do we need to do something else at this point? And we've been getting advices from them, so that when we roll out, it won't be a situation that we haven't done something and we're going back. So we're all working together.
Thank you very much, Your Excellency. So for those who whispered the question to me, he has answered. So I was going to ask you, Dr. as a president of an association of which is very involved in this area, what do you think needs to be done to prepare people, to prepare the sector to take advantage, the providers, the nurses, the pharmacists, to take advantage of this?
Okay, that will be on many fronts. First of all, I want to address that from the perspective of capacity building. One of the things that has happened, and until very recently, many of the solutions that have come into the country were imported and then were adopted and adapted to fit the system that we have. But if you understand the way health systems across the world are, health systems evolve based on the inherent needs of the people that use them. And one of the things that you find out, Nigeria has a very unique healthcare system. And if you are going to develop solutions that will solve problems into the future, then you have to think about things that are, thought out from the very bottom, from the scratch, for Nigerians, by Nigerians that have experienced the system that we have at hand. And in that regard, so until recently, you had people bring all kinds of solutions from outside the country, and then they were based on different health systems, and we tried to make the best of them. But now we now know that we have to build capacity inside the country that understand the system the way the country works, and we can develop solutions for them. So I think one of the key things that we need to also continue to focus on is capacity building for digital health in healthcare, for healthcare providers. One other thing we had before now is to have people that have been in the digital, in ICT world generally, not necessarily in healthcare. Some of them have been the ones that came up with solutions that were adapted into healthcare. But now we need to start thinking about ensuring that the people that are primarily in healthcare are able to come up with solutions that can address the challenges and the problems that they see in that sector. And that's one of the areas that I feel that the government needs to begin to focus attention on. At the society, some time recently, we had a forum, a stakeholder forum, where we tried to engage the university community, Nigeria University Commission, Nigerian Council of Nurses and Midwifery, Health Record Officers Boards, and the likes. And we started this discussion and, underscored the importance of having healthcare providers primarily get into some form of digital health. When the solutions are ready, they are the ones that are going to run them. So you might as well start introducing them into those solutions from the very scratch. And we were able to start the conversation, and as we speak, I believe a lot is currently ongoing. The Health Records Officers Registration Board have started to include digital health in their curriculum. I know some other regulatory bodies are also beginning to do that. And we need that going into the future. The Honorable Minister talked about 10 years from today. 10 years from today, we should have enough capacity to develop things without having to go outside the country if we're going to turn Nigeria, revolutionize AI in Nigeria. So that's one perspective. The other perspective is, all right, that's fine.
Okay. Sorry, thank you. I wanted to make sure, on this issue of innovation, which is really key in sort of driving this, as a member of the private sector and somebody who has an innovative approach, what do you think? Will this create the kind of platform that would help you grow?
Sure, definitely. Actually, I wanted to, when the Honorable Minister was talking, something caught my attention, which, I almost shouted, that's what we've been saying. And, it was when you talked about NIM, working with NIMC, the defragmentization of our healthcare sector is like this. I saw it today in the beginning of the speech, of the keynote address as well by the Honorable Coordinating Minister. It's one of the most important things from a policy perspective that can support healthcare businesses. So when we started out at Infinity Health, we actually started out meaning to solve the data problem. Today, we're at the forefront of making regulatory and market access as easy, for everybody who is looking to build sustainable healthcare in Nigeria, and from there we're taking it to the rest of Africa. And the reason was really simply that, when you talk about data, and we started to look at that data framework, one of the things that I also wanted to mention and to challenge at public policy level is, when we're forming those frameworks, we also need to start thinking about it from the level of input as well. So, and I'm going to give you an example. Today, you cannot, even by looking in several EMR records, tell, for example, and several death certificates, tell, for example, how many people have died of diabetes-related complications. Not because, they do not know that it was a diabetes-related complication, but, somebody has written ascites somewhere, another person wrote cardiac arrest, another person wrote, that's cause of death. And the problem now is when you feed that into, a platform like this, yes, you have data, but, it needs to be data that tells a much broader, a much bigger, a much better story. I like that, we're looking at implementing, birth and death directly into health records. One of the time, in a lot of public policy debates, and I tend to have a lot of strong opinions on those, people will say, oh, we need a tax system to do that. And I say tax is not always the best way to get people, onto a system, because when people hear tax, especially in this part of the world, there's an aversion, like, oh, I'm going to spend money. Even if they say you're not going to spend money, like, they're recording me to spend money somewhere. Healthcare is a very solid way to get people numbered and recorded from birth to death. I think it's a very fantastic initiative. I think that, it's going to tell us a whole lot more and provide opportunities. The other thing that we, that I also think in terms of, using data to navigate healthcare is that one of the things you find, so the reason we got into regulatory was because, you see, when I was trying to solve the data problem, everybody kept asking, you've done 16 years in pharma, who's your NAFDAC guy? And I'm like, why do you need a NAFDAC guy? There's the farm platform, there's all of this, but it's not clear, right? And it's no offense to anybody, but not everybody understands how to use, these things. It's not that they don't have complex processes abroad, no. It's that, It is extremely clear-cut. You need to do this, to do this, to do this, to do this, to do this. Today, we've polled, at our last poll, we started with an initial poll of over 500 businesses, where that poll has extended to almost 1,000 now. Over 92% of them do not know what is required to bring a healthcare product or healthcare facility to market. So you know what happens? They make all these great, fantastic investment decisions, and then they now come and say, the regulator is stressing me out. I don't know, oh my God, now I don't know how I'm going to get all of this and all of that. So we can also leverage data to drive market access if from the forefront we're putting in, one, the right data, we have the right framework for input, and then two, we're making, processes, we're using data to make processes very clear so that, compliance is rational and easy.
I think that's a very good way to end. Because I think the use of data is key for investments. I mean, you've talked about the group. Even pharma people wanted to invest. We just did some work with IFC to try and get data on the 10 most commonest drugs used in the country. Extremely difficult. And I think some sort of way of what you said, of maybe using the same information they also use on health insurance. I know the health insurance companies also have the same thing. Somebody has laryngitis, somebody has sore throat, somebody has, so it's very difficult, and maybe not fraud, but it makes things very difficult. So I think this is an amazing idea. I've been told I have 5 more minutes, so I'm going to ask the minister one more hard question, and then I'll let everybody else have 1 minute to round up. Minister, and everybody has talked about how you talk about monetization, they've all been so nice, but you have not told them any financial incentives for them to actually get with this program and to support AI, Nigeria as the #1 AI nation.
Okay, very good. 2 questions. Thank you, Dr. Osifo Daudu. Monetization and financial incentive, and how to, on the AI part. We're very mindful. Countries like America, when they were starting this aggressive digitalization effort, they incentivize providers to give them so much tax break, giving them direct cash. It's a program like that will be very difficult in Nigeria to do, more so in this era where the government is really struggling to put more resources together for other areas where it's desperately needed. But our indirect support is what we're doing. We're very careful. We've gotten significant budget. The president has been kind enough, because it is bought into this and is giving us all the support. We have significant budget to procure these technology solution companies, to procure the hardware. So when they come, they will get significant investment from the government starting off. And moreover, we're also going to give them the hardware procurement contract, so they'll have good margin there. Now, this is not their own investment, this is government investment. Suddenly now they are the provider, they are the providers. They will now start charging licensing fee. Going to the future now, we have 34,000 PACs in the country today. 8,000 of those PACs are working, but with a swap effort, in the next 2 years, we want to bring another 9,000 on stream. So let's just say about 20,000 primary care centers. If they're charging license fee of 1 million for that PAC to use the technology solution, that's huge money. The secondary facilities are there, the tertiary facilities are there. But not that, the secondary plug-in, where people will now begin to develop platform to plug in on the base platform. That's another, there'll be licensing fee charged there, user fee charged there, and as I said, mental health platform, care coordination, pharmacy module, which the people can market to the public as a hub. That's when you now create multiple geometrical effects where money begins to flow into that digital ecosystem, and where people will just sit in their room, build a software, build an app for patients. I want to target malaria prevalence in this area to support USAID or UNAIDS for this and this and this. That's where the incentive will come. But the base investment will be done by the federal government. We're not positioned to start giving incentive out. Now for the private sector, we're building this massive interoperable connection for them. When we get there, there might be some incentive for them to plug in, to move their data in, but that's the third phase of this program. Now with AI, of course, once we have this, people have been coming to me and say, oh, they want telemedicine, and I'm telling them, you cannot deploy telemedicine if you don't have an electronic medical record. Telemedicine, you talk to people, but the data, your encounter had to be housed somewhere for reference, for another, because if you see that patient again, how do you reference the previous data? So that's why it's so important we build this electronic medical record platform very well. And you now talk about AI. AI is your ChatGPT, everything. You need that base to layer AI on this. And that's what my friend said here, data is a fuel for AI. For you to now say, okay, AI, ChatGPT, do this for me. It has to go and source for all this data to analyze, fragment, and reproduce.
So, thank you so much, Your Excellency. I think, do we have any time for questions, or you want me to stop? Okay.
Two questions, maybe.
Okay, you have somebody at the back.
Can you let me seek the indulgence of the organizer? Please, if you can give Dr. Asif, she flew in from South Africa to do this. Give her about 20 more minutes, please. Let it be water time, please.
Okay, I think the question. Okay, what we'll do is we'll take a couple of questions and then we'll then have the answers at the same time.
All right,
okay.
Thank you very much. Good afternoon, everyone. I'm Dr. Oluwapelumi Alio, and I work for Excellence Community Education Welfare Scheme, ECUS. Thank you, distinguished panelists and Honorable Minister. It's always very good to hear leaders communicate their visions without any form of aid. People are more engaged and really know that you've internalized what you're discussing, so thank you very much for that. I have two questions, and they may be answered or considered as a recommendation. In aspect of health digitalization and so on. First is, how can we leverage that towards equitable distribution of human resource for health? That's a big challenge, and it's not unique to us in Nigeria. If you visit several local governments across the country, you find out that community health extension workers are largely the bulk of our health workforce right now. And you have nurses, doctors about to retire, and there are no system in place for them. So how can we really leverage this? Like I said, it's not unique to us. A place like India, you have like 31% of their health workers being dedicated to 71% of areas with the health disease burden. So I think it's something that is really important for us. How can we motivate people? How can we leverage on this AI to have the healthcare workforce going towards the rural areas and all that? Secondly, for us to be able to track health financing, releases and so on, that's, I think, it's been a major challenge across board. How can we also leverage the digitalization agenda to be able to track and, of course, work with Ministry of Budget and Planning, Ministry of Finance, for the private sector, for non-governmental organizations and so on, to be able to have a near real-time access to how these funds are being released for programming. It's a major challenge, and it's something that is of huge interest, I believe, to a lot of external stakeholders. Thank you very much.
Thank you. Questions?
My name is Dr. Niyi Oshamili. Honorable Minister, very good to see you again. I know in June we conferred on you associate professorship, but I think there's accelerated promotion now, and Felix has declared you a professor already. So congratulations, sir. My question, sir, towards the end, you mentioned interoperability, and so I just want clarity or a little bit of additional information, sir. There's a National Digital Health Platform, or the EMR, that is being built. I wanted to get a little bit of more information around health information exchange, and I know you mentioned interoperability towards the end of your presentation. Thank you, sir.
Okay.
All right, last question.
Good afternoon, ladies and gentlemen. Dr. Usman Al-Rashid. I work with UNICEF. Thanks to the Honorable Minister of State for very strict and direct point. My comment is that it will be very important if we can harmonize and integrate the already existing vertical data reporting system in Nigeria. DHIS2, EMR, logistics management information system, HIV, we need, if we want to go into where the mission where we want to go, we need a roadmap from the Federal Ministry of Health on digital health system in Nigeria. That it's going to help us. Not even talking of vital statistics. I was quite excited when one of the panelists talked about capturing data on death. Death reporting in Nigeria is between 5 and 10%, and we do population every 10 years. That's not good enough. What we can use to rebase our population year in, year out, forgetting about projection, is that if our vital statistics system is good on birth, on death, on marriage, on divorce, on stillbirth, I think that will really help us in putting up a better framework that can help put this country forward. Thank you very much, sir.
Thank you so much. Yeah, before the minister responds and others to the panel, we want to share with you the website of the Nigeria Digital Health Initiative so that we can go there and get more information. So we'll share the QR code, but I will just, it's very easy, www.digitalhealth.gov.ng. Let me use my Igbo man voice to tell you. www.digitalhealth.gov.ng. That way you will not forget. So they will share the QR code, but you can just quickly go there. So the RFI, the request for information is there, all the information you need, and the deadline is, I think, October 11th. It was released on 27th of September. So you are still within the time frame to submit all those who are interested. And we also, sorry? October, is it 7th? Oh, I thought 11th. Oh, I'm sorry. Okay, but.
Okay.
Okay.
Okay. All right.
Then we have some information. There's a question, sir, from the online audience so that they are not left out. It says, good day, Honorable Minister. Looking at the overall SWAP and the goal of improving population health, how can we ensure that our PSCs are well equipped with the needed skilled health workers that can help in addressing basic health challenges at rural facilities, especially with the recent local government autonomy? Jam question. All right, so I think we can take you can respond, sir.
Your Excellency, Your Excellency, before you respond, one of the questions that had been raised, which he kind of raised, was that some people felt, and I am a total, not a participant, that the time given for response was a bit short. You know, that many people did not know. So it's something that I would like to bring to your attention.
The time given for response?
The RFI.
RFI, okay,
Yeah,
okay.
Okay, several people had mentioned that it was a bit short.
Oh, okay, let me, okay. It's just, okay, we'll look into that.
Okay.
Remind me. We're trying to roll out before the end of this year. So we've built some buffer zone. We'll look into that.
I think that would be good. But I think most of the questions were for you, so...
You think so? I thought you were going to really spread it out. I was looking for you to apportion it.
Okay.
I don't, please.
But I was going to say, but a couple of things, and some of it I will, because I think there will be some other interesting responses. But I think the issue of the equitable distribution of health, I think you can respond, but also some of the entrepreneurs or innovation, there are other things that you can use that will actually help with the distribution. Because the issue of rural healthcare workers is not a Nigerian issue. This is an issue in America. They have no psychiatrists in Dakota. which is one of they spend so much on healthcare, but it will be interesting to know. The other issue was health financing, whether AI will help people see what you're doing with our money. That I think is the second question. Then there was the issue of interoperability.
How about the question?
Which you had.
Okay. Okay, I was just thinking whichever one the other panelists could take.
No, I'm going to ask them after you answer.
Very good. So let me just take them. Let me take the last one about the swap and population health outcomes, how we can skill worker and get more skilled worker. If you look at what we're doing with the swap, basically the base definition of swap is sector-wide approach, aligning, coordinating all these disparate programs, investment, going into different areas so that we can align and begin to direct to where these funds are needed most. One key area that we're doing, and we've made so much progress, is re-educating our frontline health workers. We're training 120,000 community health workers. I think we're about 65% done now. We've trained over 60-something thousand of community health workers. We've built a new standing order for them to guide them in the way things are, the way they practice, to give a robust evidence-based care to them, how they manage diarrhea, upper respiratory infection, and things like that. And with this local government autonomy, it created some problem for us because what existed before, we have the National Primary Care Development Agency, we have the State Primary Care Development Agency. A lot of these funds were flowing from the Basic Care Provision Fund. We have two major gateways, the Primary Health Care Gateway and the NHI Gateway of about 45% and Primary Care Gateway of 50%. The funds will just flow to those state sub-national agencies. Now, suddenly, we've taken, which is good. Local government autonomy is one of the best things, one of the major revolutionary policy change that the president has done for us. What we've now done is that to avoid that hiatus, to avoid that vacuum, we've sat with the governor forums to really design a way how the MPHCDA will function with the state primary care development agency. Now, that's been purely taken care of via dialogue. We were very proactive about that. So with this autonomy, local government, we're not pushing all the funding to the local government alone. And you heard Marlene talked about the OPHC, the Human Capital Opportunities for Prosperity and Equity. The World Bank just gave us a loan of almost $750 million. That for our PACs, that money will be directed mostly to the states, directly to the PHC, because it will be based on it's incentive driven, the targets that they will need to make before they get those money. Also with our swap, the money we're mobilizing will be directed towards specific programs at the primary care level. They will use the fund to build infrastructure, buy more commodities, and employ workers. So those are the three major focus where how these funds can be used. It won't be used to just continue to build structures that doesn't work for everybody. So I believe I've answered that swap and population health outcomes. With harmonization, I'm trying to, when it comes to our Nigerian Digital Health Initiative, we've done a lot. So I've been trying to just be very conscript with the messaging so that I don't get people confused here. We've done a lot of harmonization. Honestly, today, any big data source that is out there, we've spoken to them. We've spoken to the National Population Commission and how we're going to do the birth and death registry. We've spoken to NIPSI. Phase 3, where the USAID has developed this big, and I was trying to remember the name of that platform. If somebody can just refresh my memory, which is also all based on HIV. That data platform has been developed. Sorry? NDR, National Data Repository, which is very robust. But it's only it's just for HIV. But we say, no. This is good. Let's look at a way where we can plug this in, do a data dump into the national EMR. And the way we've discussed with them is that they have their own identifier number, but what they've done 2 layers of biometric fingerprinting, which they now for every patient on that NDR platform. So we will cross-match, we will do that, scrub those bioprinting with our own fingerprinting from NIN. So we can now dump those data in a way using our own NIN number as the identifier. So, and that's a big data base. We're also mapping, Global Fund is also mapping all the labs across the country. We've told them to how they will do their facility number. That will get dumped on the NHR. So one day you know where all the labs are. We've set up, we've instructed the Medical Laboratory Science Council to start an aggressive accreditation and reaccreditation of this lab so that people will now know this lab is not accredited, don't go there. We've also, we're also talking about how we can move the DHIS2 data onto this platform. That's why one of the things as we build this, the HLML5, as we build this platform, it will have extensive capacity for interoperability. But to answer your question, we get it, that's what we met. There's so much fragmentation, but we're working to harmonizing everything. And I can tell you today, as I'm talking, we've met with all this, where all these data are. We've met with them and we have planned on what we're going to do and how we're going to interface everything onto this platform. And when we move all this data into this platform, we're going to be very careful and be mindful that we're not duplicating data. Anybody that gets in will have that. It will be the base entry into the platform will be your NIN. Now, I'll jump to the first part about equitable distribution for human resource. What we're doing today, we're also mapping where there's in fact, the data, honestly, we have, this country is endowed, people have worked before, but it's just that things are just segmented, things are just fragmented there. Some people have worked to map out our human resource for it, the number of doctors we have in the country, the number of nurses, the number of community health workers. So we're moving that already, in fact, that's actually at advanced stage, moving that onto our platform so that we can begin to really know where this human resource, where this capacity has, where this capacity are. How many nurses we have in this state, how many community health workers we have in this state. So, but then, now, this will be validated data. All the things, all the softwares are talking to one another. You can have now one sole source of information that you go. So that project's already in the making, and it would actually be part of the go live. Once we go live, that data on human resource will be there. Of course, once we have that, you can begin to layer AI on top of it. You need the base EMR platform to use AI. If you don't have where you can source, pull data, you can use AI. And about health financing, if you go down, look at what most of these technology solution companies have now. They have what they call wallet. You go, you put your money there, and it works well. If I go to a hospital now in Ejabi, I put 10,000. I see a doctor. My charge is 2,500. As I'm seeing that doctor, my wallet gets depleted by 2,500. They said I need the ultrasound, 7,000. As I have that test, my wallet gets depleted. I have a balance of 500 naira. I can't access any. If I now say, oh, you need to get amoxicillin to treat your pneumonia, it costs 3,000 naira. I won't be able to get that service because I don't have enough money until I replenish that. So I say that to let you know that the technology is there already. It's just now to expand it. And that's why NHRA, we've spoken to them, they were developing their own platform. We said, no, put a hold on it. NHRA will roll onto this platform as well. So we can now begin to, once we get NHRA to roll on the platform, HMOs will roll onto it as well. So we've now layered health financing on top of it. Government health financing, private health financing, and personal health financing on this platform. So you just have to have that base. And that's why we're working so hard to make sure it's well done. And I think about I think I answered the interoperable connection as well. So with the interoperable connection, that's why the way we're doing this, I told you we have the primary data center and we have the secondary data center. The primary data center is more for us at the Ministry of Health, at PHCs, federal tertiary hospitals. As the secondary hospital, as the state hospital, subnational hospital plugs in, that will go into the secondary data center. As private sectors plug in, it will go into the secondary data center. But then that will now be a countrywide data center that we can now begin to look at this gazillion of data to really now begin to analyze, aggregate, disaggregate, and now see what we need to use here.
Thank you so much, Your Excellency. And I know that people are really very grateful and how frank you have been. But so just 1 minute for everybody else, just the last 5 words. I will start from, your last words. What do you want people to remember from today? Malise, I'm starting with you. The last, what you want people to remember for today in 5 words, 6. What do you want people to remember from today? Can you hear me?
Yes, I can hear you.
Yeah.
The absolute essential nature of the foundational investments that are needed, be it in data, be it in governance, be it in the rules of the road, the enterprise architecture that connects all these primary and secondary data centers as the Minister has outlined. We need to have these foundations in place, and once they are in place, the speed with which the country will be able to move will be astounding. Indonesia connected 400 EHRs in 18 months because they put the foundations in place, and I believe Nigeria can do it too. Thank you.
Thank you. What do you want people to remember from the panel?
So, I think the most important thing is that we definitely can use digital to leapfrog African healthcare and especially Nigerian healthcare. And as private sector, as Infinity Health Africa, we are committed to making it easier and more rational. Our goal is really to make it rational and easier for private sector players in the healthcare space to plug into government initiatives, policies, and I don't like to use the word compliance because it always sounds like something hard, but really comply. Compliance works and government work works when majority people are plugged in. The work is easier when majority of people are plugged in, and we're committed to ensuring that the majority of people are plugged into the policies and initiatives.
Thank you.
Well, maybe just 3 quick comments. First, to say that it's very clear that artificial intelligence can support in solving many of these challenges. What you were talking about, the oceans of data that are out there, free text that we need to structure and give order to so that we can use for public health purposes. That can be driven by AI, and for that, you need to put in place, and I know there's a national strategy for AI, the governance models, and I hope to see also Nigeria integrating the global governance models that is so critical and putting in place the post-market surveillance mechanisms to keep citizens safe and to maximize the impact that these technologies can have. The second comment is everything that is done truly should contribute to lowering the burden of disease, as I mentioned before. This is extremely critical to free up resources to take care of those that will need care. And this is good for business, for insurance companies and for the state. If you have lower burden of disease, people use less of the health system, and therefore you're able to treat those that need care more efficiently, and AI and technology can be a driver for that. One last comment on incentives, which we all advocate for, putting incentives connected to outcomes, but a cautionary tale, if I may, just to say that I was having a call the other day on Zoom with a colleague, and on his desk, he had his phone on a swing going back and forth. And I said, why do you have your phone on a swing on your desk? It's very disturbing. And he said, well, my insurance company gives me a premium if I do 10,000 steps a day. And so Please put in the incentives, but make sure they are right and they contribute to real health outcomes. Thank you.
Thanks very much. Okay, Dr. Wamsi, you took your last word.
That's very good. I'll take that line.
No, I think that's an amazing joke. And I can imagine here in Nigeria, we're going to have lots of swinging phones.
So, in fact, I've even heard of it on dogs. People put like their Fitbits on dogs, etc. as well. So I think what I would take is one, the recognition that innovation sits in this country. I mean, innovation is sitting in this room. We have incredible leaders that have defined the pathways, and we have a government that recognizes that and values the private sector. And so we really have to give credit to the fact that we have a government that values the private sector. And so thank you to HFN for actually having this platform for us to discuss that today. So there are opportunities. There are opportunities for innovators not to wait, but to get started today. I didn't wait. I was able to build a team, and we are serving 125,000 people today who are enrolled on our platform, but actually not just enrolled, they have the outcomes. Reduced sustained reduction in average systolic blood pressure, improved glycemic control. We are literally seeing reduction in terms of depression and anxiety symptoms, improved financial literacy. We're measuring outcomes every single day. And we're doing it through collaboration at the local level, at the state level. So that's the other element. Invest in collaboration. HFN is an example of collaboration. It's beautiful collaboration. So how do we tap into those multi-sectoral aspects? Because I'm sorry, historically, a lot of funding mechanisms have actually caused less collaboration than we've seen. So how do we create a new tomorrow in terms of how we work together to actually transform the narrative? That's the other element. And the third and final piece is around capacity building. There's so much we can do today. I'm a mechanical engineer, not an electrical engineer, but think about circuits. And what can we do in parallel and not series? A lot of times we wait for series. How can we invest in AI literacy? When MDoc started, we just started seeing, our members were showing their phone, showing their graph of their blood pressure going down, and going to the facilities and showing their nurses and doctors who are like, please, I don't even have time. See the line here, please just go away. But it wasn't because they were overburdened, but actually because they didn't have the digital literacy. So we started training. We've trained 15,000 healthcare workers today in digital literacy, in quality improvement, and now AI literacy, because we can't wait. So how do we invest today in building the capacity, the capability, so people can leverage the AI literacy? How do we invest in research and innovation? We right now got funded by Gates grant challenges to focus on the AI work we've been doing for 4 years. It showed, actually, what my colleague here highlighted, that AI, large language models, can improve, actually across board, across empathy, contextualization, completeness, accuracy, and safety. Our chatbot performed better than our doctors, nurses, and CHUs using standard clinical repository and actually even using GPT, right? So we saw the greatest improvement in community health workers. So when we talk about distribution and issues with that, there's things that can actually be done today with the right governance mechanism, so it's done responsibly and equitably and safely to solve some of our problems today. So just recognize what can you do today, not waiting for people to answer your problems tomorrow. That's the greatest thing that I've learned today.
Thank you.
All right, thank you very much. Talking about digital in health, I realized one of the main objectives is to improve patient engagement. And AI can go a long way in achieving that, because there's a gap. There are gaps between access to care today, particularly like we've all agreed to in the rural part of the country. I think we can use AI to bridge the gaps for people that are, who have access to mobile by using solutions that, support patient engagement, patient education, and learning environments. But for those that are in the rural areas, we need to also consider decision support for the care providers. The Honorable Minister talked about training about 160,000 rural care providers. We need to be able to use AI to provide them with real-time access to decision support systems. That will help them to meet the needs that the people in that part of the world, the country, happen. Thank you.
Thank you so much. Your Excellency, final words, sir.
Thank you. I would like to reassure everybody that our digitalization effort is here to stay. Everybody will be carried along. It's going to be fair, open, objectively driven. There won't be any shenanigans as we pre-qualify people, as we select solution companies that would be the providers of the EMR. But one thing I would like to say, to let everyone know, I know there are a lot of solution providers out there. We cannot accommodate everyone at this first phase. But what you should prepare for is the secondary phase, where you can have the capacity to develop multiple platform to plug in. And that's where the huge monetization is. So don't be discouraged if you're not one of the vendors, but then go and retool, repurpose your platform as a secondary platform that will latch on a primary platform, and that's where the big money is. You heard the founder of MDoc, 125,000 users on that platform, but here now we will have a platform that has a base of 10, 20, 30, 80 million people. Big country, 36 states, FCT. You can do whatever. Amazing, expansive capability to unleash your innate potential to monetize your God-given talent. Thank you.
I am sure you really like to thank the wonderful panel, and also HFN and Farm Access and all the sponsors that put together the support for this wonderful panel, and for His Excellency for spending extra time with us. I mean, this is amazing.
Thank you.
And I just want to add one thing. One of the groups we support has 160 Nigerian accents, so that you can get them easily into AML, so everybody doesn't have to type. You can also use speech recognition.
Yes, that's the power of AI, yes.
Very quickly, because
yes.
these are Nigerian guys doing this. But this
I'm sorry, Dr. Egbe just said something. In fact, time has even helped us out here. Now, people were using Dragon. Now, with AI, all these things, typing and everything, you can just, the AI will recognize your speech. You can type. Thank you.
Yes.
Yeah.
So this has been an amazing section, and really thank you so much. And thank you, Abimbola, for giving us a little extra time. Thank you very much.
All right, thank you. Sorry. Please, I wait for the picture. So we want to invite HFN sponsors to join. Yes, please, to join the group picture with the minister. JCI, others, please. Dr. K. Adeshola, who is the president of the Association of Nigerian Private Medical Practitioners, ANPMP. Dr. Adeshola, please. A big round of applause. We're almost done. So one last push. We also have the chairman of the Healthcare Providers Association of Nigeria, Lagos chapter, pharmacist Mrs. Paul Ozier. A big round of applause. We have Dr. Chito Nwana, who is the National Vice President, Guild of Medical Directors. Dr. Chito. A round of applause for her. She's making her way back into the room. Coming up. And last but not the least is Dr. Simeon Onyemachi, who is the chair for the SSHIA. We have a full panel, And Dr. Agada would lead, first of all, with some introductory remarks on behalf of Dr. Ohiri. Over to you.
Thank you very much. All protocols observed. The beautiful thing about speaking last at this time is almost everything would have been said. So you can imagine that we are making a lot of adjustments here. So on behalf of the DG CEO of National Health Insurance Authority, Dr. Kelechi Ohiri, I bring you greetings from him. He had desire to be here because of exigencies of office, he's unable to make it this afternoon. So I will give the keynote speech on his behalf, and so I will go through this quickly. On December 12, 2023, which was also the UHC Day, Mr. President approved the health sector strategic blueprint for 2023 to 2027. And one of the highlights of that approval was the Nigerian Health Sector Renewal Investment Initiative, which is being led by the Honorable Coordinating Minister of Health and Social Welfare. To holistically address the suboptimal performance of the health sector, the President also approved the adoption of the sector-wide approach as the guiding strategy for the implementation. This approach allows for effective coordination of actions and resources to support the achievement of national priorities through common management systems guided by agreed policies, expenditure and institutional framework, as well as strong accountability systems. The SWAP approach prioritizes the enhancement of resource coordination and efficiency, strengthening of governance and accountability, empowerment of state-level health systems, promotion of universal health coverage, and strengthening of ownership, visibility, and communication of actions and results. So driving down, at the very core of the SWAP approach are the 4 ones: one plan, one budget, one report, and one conversation. SWAP one plan seeks to ensure that all stakeholders' efforts are aligned and directed towards attaining our common health sector goals of saving lives, reducing physical and financial pains, and producing health for all Nigerians and legal residents. This health sector goal has been broken down into 4 pillars. We've heard so much about the pillars today, and the 12 major strategies. We have also heard about that when the coordinating minister was speaking. Our one plan and strategy must be implemented through government systems, hence the signing of a service compact between the federal and state government, as well as development partners. Under this arrangement, the NHSRII and HSSD are translated into annual operating plans, which prioritizes country strategies to achieve desired results. In addition, this allows for development partners to provide technical support. How do we overcome barriers to implementation of plans in the health sector? Over the years, many barriers have impeded the implementation of various health sector plans. The Nigerian Health Sector Renewal Investment and Initiative and SWAP include clear strategies that will help overcome barriers to implementation. For example, such measures are being implemented to deal with barriers in health insurance ecosystem, which is the focus of this session. This includes measures to strengthen oversight on implementation, accountability for results, and participation of relevant stakeholders, including citizens. To also strengthen regulatory capacity within the sector to foster the highest standard of service provision, as well as health insurance ecosystem. It's also to improve the quality of care and service delivery across public, secondary, tertiary, and quaternary and private healthcare providers, to improve equity and affordability of quality care for patients, and to expand insurance, to shape markets to ensure sustainable local demand. Policy-wise, the enactment of the NHIA Act of 2022 provided a basis for effective regulation of the health insurance schemes and implement health insurance across the country. These include insurers, purchasers, administrators within the public and private sector. NHIA is implementing ongoing reforms to transition it into an effective regulator. In line with the SWOP objective, stronger synergy between the various institutions involved with health insurance is helping us monitor progress with the enrollment of Nigeria. And as we speak, so at every particular time, we are able to tell you how many Nigerians are registered under health insurance. Regarding health insurance coverage, enrollment grew by 14% between Q3 of 2023 and Q3 of 2024. The growth has been due to the effort of the NHIA, the state health insurance agencies, and private health maintenance organizations. Currently, 97% of federal MDAs, ministries, departments, and agencies have been enrolled into the NHIA organized public and private sector programs. Thank you very much. All states have also established health insurance agencies or programs. The establishment of the Vulnerable Group Fund and provision of funds in the 2024 Appropriation Act are steps towards ensuring the vulnerable are not left behind in the implementation of the Act. The Fistula-Free program initiated by the NHIA has enabled the treatment of over 500 women with VVF or obstetric fistulas, and provided the opportunity for their enrollment into health insurance. A total of 15 fistula centers across Nigeria are currently participating in expanding the initiative. The main gap currently is with the provision of financial risk protection for the large informal sector population in Nigeria. Enrollment has been negatively impacted by the ability to pay, the willingness or unwillingness to pay, and in some cases, their lack of awareness. Initiatives to overcome these barriers include development of digital enrollment platforms. We have heard so many about AI and digital platforms today. Partnership with telecommunications companies, collaboration with corporate entities that serve and target MSMEs, creation of flexible premium payment options, an effort to ensure compliance of organizations with the mandate of ensuring employees are enrolled under health insurance. These strategies will be complemented by the intervention to socialize health insurance across multi-channels to create an understanding of the prospective benefit of health insurance. Further actions need to be considered include the federal government revenue needs to grow significantly in the next 6 years to increase funds allocated for the Vulnerable Group Fund. We need to do more investment to capture the market, especially for the informal sector, which is a problem for health insurance all over the world. Wherever you have large informal sector, innovative ideas will have to come into enrollment of the population. Private sector initiatives are needed to increase the coverage for the informal sector. New and updated regulations will encourage innovation aimed at driving enrollment across all segments of the addressable population. State and local governments would increase coverage by providing health insurance for all their workers and also look at designing programs for the vulnerable population. In conclusion, achieving the one plan goal of SWAP requires having a unified approach and plan for the pooling of resources and integrating efforts to achieve our health priorities in Nigeria. This means that the private sector must be willing to contribute its quota. The plans provide the opportunity for strengthening existing systems, ensuring adequate coordination, institutionalizing accountability mechanisms, and effectively managing the required changes at all levels. Thank you very much for listening. So at this point, I will hand over to the moderator. Thank you.
Okay, thank you very much, Dr. Guda, and thank you very much for the rest of you who are still left with us. We know that we are the ones keeping you between your lunch, so we will keep it as brief as possible. However, I beg to crave your indulgence to give us a bit of patience so that we have this panel, because I know the rest of the panelists have been waiting patiently. But what I will do is consolidate my questions just for speed, and also to make sure we have a robust discussion within the limited time we have left. So we've really heard a lot about what SWAP really is. I think the Honorable Coordinating Minister really elaborated in the framework, and we were given a big picture into why the SWAP approach is being used in order to ensure that we have one plan, one budget, one compensation, and ensure that everybody is aligned and one reporting system. So really, the question really, and the genesis of this dialogue today is, where is the voice? Where does the private sector kind of fit into this SWAP approach in now addressing all the challenges we have in our health sector? And all of you, most of you here, represent associations. So behind you are a large number of organizations and individuals. So you're here representing almost their voice. So given what the Honorable Minister said in terms of, he threw the gauntlet down and said, anybody who has an idea, please come forward. And we're willing to listen. So now, taking this message to your associations, so maybe I'll start at the very top with pharmacist Paul Ozier, and then I'll go next to Dr. Adeshola. What strategies do you think your associations can now use to advocate for inclusion of the private sector in this national funded program under SWAP, given what you've heard today?
Okay, thank you very much. I really want to, first of all, appreciate the HFN for organizing this program. It's really an eye-opener. One thing that we have had over the years in Nigeria and in the health sector in particular is that whenever policies are made, whenever programs are initiated, more often than not, the private sector is the last to know about those policies, about the program. And in this case of the adoption of SWAP, I think the same thing is still applicable. You can only disseminate the information you have had. If you have not had it, the likelihood, or you've had it, you have not even understood it, the likelihood that you disseminate that information is very, very slim. because the people you are taking it to, don't forget that these are healthcare professionals, and those of us in the private sector, we have a whole lot of goals and objectives that we must achieve privately with all the kind of the economic scenario we have in Nigeria. So when we are the last to hear about programs and policies, it's going to be difficult for us to tag along with government. And so, based on the question you are asking, now that some of us are realizing, we are learning, we know that SWAP is not a program like the Honorable Minister have mentioned. Rather, it is an approach. What we have also read in the news is that this approach has been used in the banking sector and some other sector. Now we want to use it in the healthcare sector. And so, like they say, charity begins at home. The federal government herself must be serious about this and must be seen to be serious about this approach. We cannot, we cannot say, now this is the approach, and you have left the group that caters for about 50% of the services, you have left that person behind. And I could see in the presentation of the representative of, I think, the NPHDC, he put one plan, one budget, one report, one conversation. And under the one plan, I'm not seeing anything mentioned about private sector. Under the one report or under the one budget, yes, I'm seeing public or private. I'm seeing public there. Definitely the budget of the private is not coming under the budget of the public. But that we have not even mentioned in those pillars that, look, the private sector is inclusive in this plan. Shows that, any private practitioner that sees it will just say, this does not concern me. This is just one of those things being initiated by the government. Oh, we will soon see that they will soon fall flat on it. So from the onset, before we can say we are carrying a message, it should be inbuilt that the private sector must be carried along. Recently, we've had some engagement. And I see the idea, the attitude of the people in the public sector, the policymaker, is that, oh, the private sector is for profit. What level of profit do we really make? We had Dr. Onya, when she came and she mentioned that for 4 years, she could not even break even. Now, the 5th year, the whole contract is exhausted, and if she really, maybe if she had been worked up and she felt, it's not worth it, she'll just walk away. But, this is the time she can actually begin to benefit. An organization that is helping in doing the same thing was able to say, look, we got to a point that it's like our fund managers feel we can't continue this. So please, what I want to say is that as private sector, we should be carried along from the onset. It should be built. Now, what will I do? I'm going to take the message back. I only hope, I believe that when pharmacist Akin, when she was talking, one of our MC here today, when she was talking, she mentioned, she asked that the slides should be given to us, the presentation. It's a welcome thing because we have to really go back, read it, understand it, and then begin to take it back to our level. And one area I want to mention is on capacity building. We all have councils. There is the MDCN, there is the PCN, there is the MLS-SCN, and all those groups, one of the things that's common to this professional is what we call mandatory continuing education. This one plan, this SWAP, should fall under mandatory continuing education. In the next cycle, it should be there for people to even understand. You can't bring any information, you cannot submit, you can't share any knowledge with the government, with the policymaker, what you don't even understand. So we must understand it at our level. For my own association, we'll be having our AGM next week. It's going to be mentioned that, look, this is the approach so that we can get you know, better outcomes, better health outcomes, like the minister mentioned, population health outcomes. We want to get it. We are also ashamed of those indices we see in Nigeria, the maternal mortality rate, the infant mortality rate. No, those things are not good enough for us. And so we must work together to make sure that we improve our health indices. And so from our own side, we are going to go back, enlighten our members, and I think along the line we might be calling upon some people in the government sector to come and also educate us on this.
Yeah. Thank you so much. Thank you so much for that, Pharmacist Paul Ose. I think to your very last point, I do agree, because there are technical sessions with the states for the swap, but there clearly hasn't been anything put in place for private sector, because you're very right. We all hear these acronyms and we now start repeating them one after the other, but we don't always fully understand it until we ourselves have to go and educate ourselves. But getting that knowledge from the very people who put in place these policies really would help a lot. I want to ask the same question to you, Dr. Adeshola, because you represent private physicians, and that's the similar challenge, as was just highlighted, in that the private sector is always the last to know. So, private physicians yourselves, were you the last? Did you hear this through the grapevine, so to speak, or did you feel you were physicians? Do you think you were part of understanding the process from the beginning?
Thank you very much. Once more, I also want to appreciate the organizers. I'm talking of the HFN, doing very well in the health space. Like the last speaker said, the experience is not anything better with us. And we've actually, over the years, cried from time to time over things they wanted to do for them to succeed. I mean, the public sector now, or most of the government policies, they want it implemented. And I've been to so many fora in this country where we have gatherings like this. Nobody has ever told me that the private sector is too insignificant or not needed for us to have any major achievement in any of the things we are pushing in the health sector. A lot of people will tell you the private sector constitutes about 70%, and at quite a number of fora I've had to put it to them. That even those of us that said went to medical school, assuming you abandon 70% of your syllabus and you face 30%, we all know what it means in medical school. You won't get 30%, 30 over 30. Now, assuming you even got that 30 over 30, how does that help a program that's programmed, you know, to function on 100%, where you have now scored 30 over 30? That's 30 over 100. And that's why there's been a lot of policy failures. Unless they come to own up that, look, you people are not really significant. But if we are, then we must face reality. In fact, I've been so impressed today with the way the two ministers have been trying to impress it on us that they care so much about the private sector. Just about last week, we had a medical expo under NMA in Lagos, and you need to see what was showcased. And this is what we've been telling them. The best of facilities in this country are in the private sector. And many of them, even the public officers that have spoken there today, they own up to you that when you bring in the private expertise, you get better results. That issue of just working with abandonment, whether it works out or not, does not work with us in the private sector. We want to invest and get results. And one other thing we should all, if we are all going to be under one roof, as it's been said now, one plan, then all of us should agree that every stakeholder matters. Whether you are even 30% or 50% or whatever percentage, every stakeholder matters. Otherwise, we are just going to be planning what will fail. If it's not going to fail, then you're not going to get the best of results, best of health outcome. And that's why we are where we are today. The private health sector has a lot of expertise that it's not being overstated. If we tell you if you know the way some of the private practitioners survive, how they adapt, and how they do things to the deepest villages and wherever you are. Our members are available across. That widespread alone is an asset for you to leverage on and deploy most of these things. But like the last speaker just told us, most of the time these things are just done either with that disregard or just that, look, we are the custodians of enforcement. Let's do it, we'll force it down their throats. And it's not working out. It's not been working over the years. It's so painful now that we are not able to, we didn't have the opportunity to say this much, while the champions of this particular cause, while they were still around. They came in, spoke, and left. So we didn't have the opportunity to put it to them, except once in a while when we meet them, we tell them, look, this thing you are promoting now is not likely to fly with us. Why is it not going to fly? Because like the late MK Abiola told them at his stage, cannot shave a man's head in his absence. 70% is significant enough for you to know that for this particular program to succeed, you must carry along these people. Telling me about going back to talk to my people, luckily, the flyer, the program, I told my Secretary General to fly it, and quite a number of people were sending messages, to me. So some are following, but we all have this particular feeling of being neglected most times, only to be dragged in at the point of implementation. I would have loved the Honorable Minister of State to still be here when I'm talking now, because along the line, planning the city stuff they are planning now, you could see that most of the things will start off with the public sector as well. They wanted to have gone a long way before you begin to bring in the private. Somebody asked that question here, but we're still talking about here. It will still end up being owned by the private sector, but not at a later stage. And those data you want to refine, you want quality data to come out of what we want to do, so that whatever we do, which is called evidence-based, will be based on something reliable, not just data thrown from nowhere or unverifiable data. So with that one in place, they will have gone far before saying, oh, private sector should now be brought on board. And in that way, sometimes some people are not even interested. And those are interested, they get lost along the line. Or the whole thing becomes muddled up. So we are saying it's good that the pharmacist has just told us that. And it is true. I'm echoing that again and again. And it's a message that we continue to preach everywhere we have time, we have the opportunity to talk, that we must be a vital part of, from the planning, from the initial stage. That is what we think will work for all of us, so that we can then agree that we're actually having one plan under one roof, and then be able to get a very, a reasonable and reliable outcome.
Yeah, thank you so much for that. I think in a way, if we're honest with ourselves, this preceded the swap. The private sector has never really fully been integrated into the public health sector, even though over 70% of people get their care from the private sector. But you just sense that the public sector has never quite understood how to work with the private sector and bringing them in. And this is just another edition of it. However, we have to appreciate that we actually have a government that actually is engaging with the private sector. Previous governments have not quite understood. So let's take this as a starting point and, yes, build on it. Same question to you, Dr. Chito, because you represent the Guild of Medical Directors. And in that vein, same question. This is new. How are you going to now take this forward?
I think this is I'm very happy with that I'm part of this dialogue, that we're part of this dialogue. And I would just say, so that you can take away any bias or prejudice from what I'm going to say, is that yes, I'm an owner of a private health facility, but I also engage government by adopting a PHC with its challenges, as Dr. Onya mentioned, but this is an FCT. But I remember when I was hearing what was going on here, I was taking notes. And I just first heard about SWAP yesterday, and as you know, I've been trying to figure out what does this mean. I've been listening through this meeting and trying to figure out where do we fit in as private health facilities. And honestly, I still don't understand. I haven't gotten it at all. And yes, so I do agree with the previous speakers on this matter, but I'm going to say why, okay? I once went to a village in Anambra State to do medical outreach, because we do a lot of outreach in different states. And one village we went to in particular had only one health center providing care for those people in the village, and that was a private health facility. All right, and the primary health center in that place was closed up with grass growing over, like nobody has been there for years. So I do agree that this government, yes, has started talking to private sector and engaging private sector on a larger scale and large scale, but in the private sector, they have ignored private health facilities and private practitioners. And I think that's something that we must make clear, because when I go to meetings like this and I hear about stakeholder in private sector, pharmaceutical companies and all this, I keep stretching my ear. How about the deliverer of healthcare in that space? So one of the biggest things I will say as a barrier to this SWAP program is an effective engagement of private health facilities. And it is really important because it's key. It's a great plan, may work, but the goal of the plan is to improve access to healthcare, right? To improve indices. But how would you do that if the deliverer of the care is disconnected from what you're talking about? How do you do that if the person that's meant to deliver that care, for example, in that community, has no idea of what the government is planning or stating? So while I was going through the meeting, I made some points here in terms of what are the root causes of this ineffective engagement. And one, I would say, lack of formal communication channels. I mean, you're into communication, but that's something that's really important. There's a lack of any formal communication channel between the government and the private health sector. Because when we talk about private sector is huge, and it involves different things. Every time I talk to my colleagues in maybe USID and the rest, I'm always arguing with them that is what you're doing, does it show in the grassroots? I've worked in rural areas, I've worked in the private sector, so I can say, does it really show at the bottom? And it doesn't, because there's a lack of communication channel. Right now, we're pretty much running a two-tier health system, where the private health facilities are running in isolation, and that's dangerous, because it will definitely impact the people at the grassroots level. And I must say that one of the reasons why I'm passionate about this, not because I only represent the private health facilities, but there has to be a voice for the voiceless. And this whole thing we're doing is for those average Nigerian citizens and vulnerable population that don't have care. So one has to speak about it. Another thing goes poor awareness of government programs. There's a study that showed that less than 30% of private health facilities in rural areas know anything that's happening in the government. We talk about it in high-level meetings, but they have no idea what that's happening. Another one is, I put the lack of information, yes. And then another thing is that we must understand that the impact of disconnect will actually affect access to healthcare and actually worsen some of these indices. So one of the topic here was, how do we overcome these barriers? What is the great idea? What is the big idea from the private health facility point of view? They should please establish a direct engagement platform. And this can be in form of task force, can be digital, but we have to have a system between the government and us that allows us to understand what they're doing and the programs. Another big thing I want to say, they need to include us in policy development. They need to bring us to the table in the beginning, even if they feel that we know nothing. But one thing we do know is that we have an idea of the local health challenges that we face and be able to deliver this care, and that is important to any health policy being made at this time. And that's something that we're told at the end what they're to do. I remember in the last Health Watch conference, I had a picture that really depicts what I feel the government's about. This large man with a megaphone, just imagine a large man with a megaphone yelling at a small little man who is trying to close their ears just so that they can not get deaf. And at the end of the day, the large man is the government, and the little man is the private health sector, who is just being told this is what we're to do, but then it definitely affects implementation. You cannot have implementation without engaging with the people that deliver the care. And in engaging that, so yes, funds are important. Engaging private sector, which they've been doing an amazing job in to get funds, is important. But human resources in healthcare is actually also very important. So I really believe that we need to fix this from that point of view. And coming from where we are owners of private health facilities all over Nigeria, and where most of the major hospitals are members of our organization, this is really important because we can bridge the gap and we can do so much. And I will talk about the elephant in the room as well, and since NHI is here, is that we need to remove friction. One of the things that disrupt the engagement between us and the government is mistrust from the angle of the private health sector, and prejudice and bias from the government of who we are and what we do. Dr. Onya was here, who talked about how she engaged with the government of Delta. I'm here saying, oh, I've adopted a PhD in FCT. Are we really all about profit? Of course, if you're in business, you're about profits because you want to keep your door open, but does not mean we don't have the heart to help and work with the government to bridge the gap. So I will take that, and I mentioned NHI here because that's one of our forms, that's an example of an engagement with government that has kind of, is still very much friction, but I wanted to commend the present DG, who has started working really hard in trying to do his data, do his research, and say, yes, you know what, we have to fix this constant friction we have in NHIA. We need to remove the frictions, we need to remove our prejudice, we need to have bias, because it doesn't only affect the government, it affects us too as private health facilities. And there will be so much gain if we can actually effectively engage, and many studies have supported that, and I'm sure we'll be able to carry on the plan of the government. Right now, I don't understand SWAP, so I can't even explain SWAP to anybody else. And I don't know how we fit in, or if we do fit in, or we're even part of it. So I think that's where I'll just stop there.
Okay, thank you very much, Dr. Chito. And to your last question, or to your last, points about engaging with government and particular frictions, we have on this panel the CEO of the State Social Health Insurance Agency, Dr. Onyamechi. And you represent Anambra State Social Health Insurance. So to the point that was just made, and given the discussions around how private sector is not integrated, carried along from the very onset, one of the key things at the state level that you're responsible for, and all the other states are trying to do, is increase enrollment. And it was quite encouraging that we heard that enrollment has gone up 40%. That was what Dr. Agudu said. So from what we've just heard and what you've heard from the associations, how are you, given that SWAP is aiming to streamline funding, one budget, how are you now thinking of working with that private sector to bridge that trust, but the important role of the private sector in ensuring that you push up and drive increased enrollment at the state level? How are you going about doing that?
Thank you so much. Just to say, for starters, I understand perfectly that running private facilities, for instance, whether you're running a community pharmacy, you're running a standalone laboratory, or a private hospital, like we'll classify in the past to say private for profit, faith-based, and what have you. Now, people do that devoid of any form of subsidy from government. So those who you are competing with, if that is the right word to use, are already miles ahead because they've got salaries to be paid for by government and all that. The running costs, government will take care sometimes of the power bills, government provides water and what have you. But you subsidize yourself fully. That point made on one hand. Now, in the spirit of SWAP, one plan, one budget, one report, one conversation, it is important for us as a country to draw a line at this point to end the era of us versus them. This is one country. If we must succeed, we must think together, what can we do going forward? now to the question I have been asked. Under the swap arrangement, we have very clear items that the Honorable Coordinating Minister spoke to, as well as when the swap national coordinator, though represented, made his presentation. I saw somewhere in that document, 40 million USD will get into health insurance. In the presentation that was just made by Dr. Agada, there is the Vulnerable Group Fund, which is provided by the National Health Insurance Authority Act 2022, which have spelled out clearly that as a country, we are committed going forward to having vulnerable Nigerians, about 83 million of them captured from that work that was done in the past, to say we have to be intentional about providing health insurance premium for these individuals because they cannot pay for themselves. Take that down to what we currently have, the Basic Healthcare Provision Fund. Even in the current state where we've got over 2 million Nigerians benefiting from that system, being implemented by the state social health insurance schemes across the country. Now, the modality for implementation is such that you've got the demand side, which is what the health insurance schemes, whether HMOs, whether you're talking about the state social health insurance schemes, are doing, versus the supply side, which is where the healthcare providers come in. Looking at the landscape of the country, when you move from the northwest to northeast, you have preponderance of public sector facilities. But then when you start getting to the north central zone, you're getting an admixture between 50-50 or 45 public and then 55 private. But then when you get down core south, southeast, southwest, it flips to largely private sector driven. In all of these healthcare providers that have been empaneled on the health insurance implementation pathway, you have, talking for a number, for instance, over 73% of the facilities are private providers. If you take that, what happens around the number is mirrored across the southeast, south, and largely the southwest zones. Now, where we are talking about one plan, one conversation, one report, one everything 111. Now, you have that. This increased funding that is going to come into the sector, if we are going to route them through these pathways, whether it's a RESMAT program, I'm in the Committee for National Emergency Medical Treatment Committee, where we are talking about the ambulance system. For Anambra, for example, all the ambulances we have accredited as of this minute that are providing services, of the 29 of them, only one belongs to the public sector. The other 28 are private sector driven. Now, all of this funding coming from the national government, whether through development partners or what have you, that will eventually find itself in all these government programs, is what this minister is all about. We cannot have inefficiencies. Let us stop verticalizing programs and harness all of these resources to then fund what are our critical requirements. At the point of implementation, every private sector provider will then give these services to the end users. And that's where there is job for all of us to do. So when you look at the way the service delivery based on ownership, whether public versus private, is arranged across the country, then you see where those monies will go to. So at that point, where those monies will get there, we need to begin to really speak to ourselves in the spirit of one conversation. Let the era of having health insurance patients walking into our facilities and then we keep them somewhere, give them shitty treatment, permit my language, because they have walked in with health insurance cards in private facilities. Please let us end it in that spirit of having one conversation. If we continue to do that, to discriminate and render deliberately, deny them services that have been paid for, then the drive to get Nigerians to adopt the global best practice, which is having one form of prepayment or the other, will be defeated. If I get poor services today from a particular facility, I will go out by word of mouth and discourage the next chap who wants to pay premium to join health insurance. We cannot, for a commodity as risky and unpredictable as healthcare, base it on what I prefer to call cash and carry health system. The onus lies on us. That is one key role I see. the private sector need to have. When we were to start in Anambra, for instance, Anambra State Health Insurance Scheme, my early days in 2018, I remember that my elder brother there, his colleague in Anambra at the point, wrote a letter after we invited healthcare providers to a meeting to say the state governments are not of age at this point to begin to implement health insurance schemes. No private provider should attend that meeting. When some of them eventually came and we had these conversations, he still issued another letter to say, we will take you out. And then you now begin to ask yourself, when there are national policies and deliberately actors at the subnational levels are deliberately trying to engage with private providers, please let us think in the spirit of one conversation. Honorable Community Minister, one last thing I will say was from what he said, let us not think through there's a problem, I have one solution, and then I'm looking for the problem. To a point where we know we have a problem, let us together look for how we can fix it. Thank you.
I think what's very clear, and what's clear for me throughout the listening, or the different, what people have said throughout today, is fragmentation has been one of our biggest enemies. We have public sector, private sector. Because technically, if we talk about health insurance, it shouldn't matter whether someone's health insurance is private or from the states. But the problem from the very onset is that these policies are often developed, but then the people who now implement and the people who are at the service delivery are the private sector. So the policy is developed, then it's now the private sector that has to now come keen and deliver a lot of those services, given that 70% of our healthcare is in the private sector. So clearly, the private sector is critical in ensuring we have a good health system in Nigeria. My last question is to Dr. Agada, because we're way past time. We're going to get kicked out, and I know Bimbola's looking at me with love, of course. And then I'll ask everybody just to sum up. But my question really to you is, based on what you said about having ramped up the number of enrollees in the last 2 months, am I correct? How can, yes, speaking of private sector, what role really do you want the private sector to play in ramping up those figures at a much higher rate than you've achieved so far?
Thank you very much, moderator. And I must start by appreciating Dr. Chito for mentioning NHI. It means, I think that as a compliment. It means NHI is doing so well. So back to the question, there are several ways that the private sector can aid the health insurance industry, and not just NHI, in enrolling Nigerians. The critical problem we have is that of the informal sector. The formal sector is, like we all know, the formal sector of the economy is usually organized and all that. So getting their premium is a lot easier than getting the informal sector in. And so the critical sector, and fortunately for us, or unfortunately, the informal sector forms the largest portion of the population. We are this low with the coverage of health insurance in Nigeria because of the level of the informal sector. And so we need to develop innovative ways of enrolling. And so I'm going to dwell more on enrollment, providing quality care, enrollment. So for enrollment, we need the private sector to come in with a lot of innovations. We've spent a lot of time here today on ICT and deployment of ICT for the best practices in health insurance and the health sector as a whole. So we need to be able to deploy those innovations to be able to do that. Data is key, and we know that this is also another key area that the private sector can help us to come in and bring in data. As we speak, we're in the midst of conducting some actuarial analysis, and part of it is the issue of data. We need the private healthcare facilities, the private practitioners, and even the private sector as a whole to help us to have that efficiency in the ability to be able to gather data in every part of the journey of implementation. We also have to call on the private sector to be able to use the efficiencies that exist so much in that sector. The private sector all over the world is known for the capacity in the area of efficiency. We believe that if the private sector were to come in with that, we've seen examples of that, of PPP, like we have heard today, and even in various our interactions with the private sector, we see how that has been deployed to have a lot of efficiency gains in the practices. Finally, I want to talk about creation of awareness. And right now, from what we have heard from all the speakers, at least the first three speakers, there's the issue of awareness. Now that we are here as representative of people, we should be able to go back and create awareness. Awareness, the benefit of health insurance, and when you are enrolled under health insurance, what are the benefits that accrues to you? We should be able to make people aware of that and get them to be able to register. I think I can say those are the points that I have.
Thank you very much for that, Dr. Agada. I think definitely the literacy in terms of understanding why people need health insurance still lacks. People don't fully understand the benefits of health insurance. I've had somebody once ask me, if I don't get sick, can I get my money back at the end of the year? This clearly shows a gap in knowledge of how health insurance actually works. So you need to, I think we definitely need to bridge that gap. But not to keep the delegates any longer, I'll just give you all 1 minute. I have my stopwatch, so I can see 1 minute. When it's, I can already see we're way over time. So this is really, respectfully, 1 minute. And I'll start from the very end. Dr. Onyamaichi, what's your one takeaway, I think, from your perspective at the state level in terms of private sector being critical? What will you now take forward in thinking not just private sector as an afterthought, but private sector really been integrated fully going forwards so that we don't have these conversations where we didn't know about it, we're the last to know. What are your one key takeaways? And so for the rest of you also similarly, we know that there are definite gaps in knowledge. You mentioned you just found out about SWAP yesterday, but definitely when you go to your members, what is the one takeaway you will actually say, yes, today was beneficial because we learned this, and this is what we're going to push forward, going forward. So starting with you, Dr. Onyamaichi.
Thank you so much. One key thing that has come out, hearing from this side, that I'm just hearing about SWAP for the first time, that jolted me a bit. I will be very explicit with my members that, dear colleagues, we need to please get back to our states and begin to unpack these things. Let the healthcare providers across board understand that this SWAP thing is not something hanging in the air. It's time for us to collaborate a bit more. A lot of resources will come in, but how we utilize them, thinking about outcomes and the impact on Nigerians will be the way to go, rather than us really thinking only about what is in it for me. And together, we can actually change the narrative.
Thank you. Similarly to you, Dr. Agada, and then, yeah.
Thank you very much. The one message that I think is very important is that the SWAP approach has come to stay. And the SWAP approach is actually our initiative for all Nigerians. It's not for public sector. It's for everybody. And when we deploy it and we work with it and we ensure that it works, it's going to benefit all Nigerians. Thank you very much.
Okay, pharmacist
okay. Really, I'll be doing my constituency a lot of disservice if I don't mention some teething problems in the implementation of the National Health Insurance scheme. Really, you know, in the with the 1999 Act, it was not mandatory. But now, since 2 years ago, we have an NHIA Act 2022 that says it's now mandatory. We can't, as healthcare providers, especially in Lagos, that we have the largest number of private healthcare facilities, and providers, we can't feel NHIA. We can't feel them. I had expected that now that we have a mandatory scheme, the NHIA will swing into action to accredit and re-accredit members, more healthcare personnel, facilities. That has not happened in the last 2 years. Though today we have heard that there are some reforms, but we are yet to see those reforms. I know about 3 months ago, there was a gathering here, the DG was there, some of the healthcare providers, healthcare associations were here, and then they arrived at some things, like just increasing the tariff that has been there in the last, 10, 15 years. That is not acceptable for the private sector to be able to have trust in our system, in whatsoever government have put on the table. We need to be proactive. I don't think NHIA, and I want that message to go back to the DG. The NHIA has not been proactive at all. I had visited the zonal coordinator in Lagos, and the language, the body language is that, it's like, we go at our pace. And I think their pace, that pace will not make us to attain universal health coverage at that 2030 that we mentioned. It's not going to be possible. A lot has to be taken into consideration with healthcare financing in Nigeria as a whole. And NHIA has to be on top of the job as a regulator. We are not seeing that yet. We are not seeing that yet. Then things like tariffs, they have to be revisited regularly. We know how the economy has been in the last 1.5 years, and we are still running the tariff of years ago. No, that's not going to work. We know what medical consumable drug items have turned to with some of the manufacturer or importers walking away, multinational companies walking away. These are things that has to be taken into consideration. And I want to sound this warning on segregation of facilities. Today we have mentioned it. Secondary care facilities and tertiary care facilities, they are referral centers. The primary, the basic health care provision should be done by primary health care centers together with the private clinics and hospitals. A situation where people, they take their basic health care provision from general hospital and teaching hospital is not acceptable, and it's not going to help us. And I must say something. One of the errors under NHIS scheme was this issue of global competition. Over the years, as an association, as HCPAN, we have spoken against this thing, that it is not right for a primary care provider to pocket the money and be the one disbursing. The primary care provider is a medical practitioner. It's not an economist. No, not at all. And so we should not permit that. I was surprised when after all the meetings, we still left it at that global competition. It's not going to work. It's not going to put trust among healthcare professionals. Neither will it generate the kind of enrollment we want in the public space. And I also want to say this too. It is important we realize that the payment mechanism should be either capitation or fee for service as it is. Referral is key. We must have it. There must be professionalism. We are talking about, people living in Nigeria. Why won't they live when they don't have? It's only a few percentage of healthcare providers that can behave the way Dr. Oye has behaved. And we need to make sure that we do things right.
I think your message and your passion. I think all those who are here representing the DG, NHIA, you know what message you need to take back to him. It's been heard loud and clear. Thank you so much for that. Dr. Adeshola.
Thank you very much. I think next time you don't make me sit next to.
It's good to have these. It's good to have these.
Sister Abiola. Sometimes maybe she peeps into my note. I don't know. So I think hear us again. We will not mind if we have the concept swap working in our health sector. We all know it will help our goals of having good health outcome. Like we all know, health is one item that every human being needs. whether you are the president or the messenger, whether you are white or black, health issue is something that is universal. And that is the more reason why some of us will always want to support any initiative that will bring health to availability before any human being. I heard my very good brother, Dr. Agada, NHI DG rep, here. I heard him. But I want to tell us one thing. On the 19th of May, 2022, the immediate past president of the country signed into law that act, and that has mandated every human being resident in Nigeria should be enrolled, should have a health insurance package. Whichever type you want to have is secondary, but you must at least have the basic thing. Now, why can't we say at this point, from that 3.5 or 3 point something million over almost 20 years, that we are now doing like 40 million by now? Why can't we wait for every transaction in this country? Whether I want to enroll my children in school, I must tender my health insurance, whatever. Whether I want to take my passport, I must take health insurance. I want to take contracts from government. Myself, my workers must have our health insurance certificates. There are many points of catching people, getting them enrolled in this country. What we've been practicing is not health insurance. For many of our members, over 10, 15 years, 19 years, you gave them 5, 6, 7, 10 enrollees, and you call that health insurance. You pay me 750 naira to treat a human being in 2024, and then you gave me altogether about 7 patients. 7 patients times 750. One person coming cannot even pay consultation fee. Let's take away consultation fee. Whatever it is you want to give, you can't give. And so some of us, why you also see segregation, people will come, is it a health insurance patient, go to that side. If it is somebody paying out of pocket, you treat it better. It's not good for all of us. No. And like I said, some of us that are sitting down in Abuja here, not minding those of us in other parts of the country, thinking that if you are sick, you need 2 million, you can get it. Are you existing in isolation?
Thank you.
Don't
so
you
much
have relatives,
that,
other people all over the place?
Thank you very much for that. Good. That's a very good point made. And we know that Lagos State has an executive order now pushing forward. So let's see how that pans out, and whether that's a model that can now ensure that everybody's insured if you want to seek any public services. And last but not least,
okay,
Dr.
and I'll stick to 1 minute.
1 minute.
But I had to write this down, so I'm going to read what I wrote. The private health sector, particularly private health facilities, are not just important, they are essential to Nigerians' healthcare system. The disconnect between these facilities and the government is costing lives, reducing access to care, and creating disparities in healthcare quality. If we are to create a strong, sustainable healthcare system, both the government and the private health facilities must engage actively and transparently. Yeah. As we push for reform, let us remember that no healthcare facility is too small to make a difference, and no community should be left behind. By establishing clear communication, including private facilities in policy making, and creating systems of mutual accountability, we can build a healthcare system where every Nigerian, no matter how remote their community is, has access to the care they need. Thank you.
Thank you very much. I'd like you to please join me in really thanking these panelists for a very impassioned discussion. I think we've learned a lot. Thank you very much for your patience. Abimbola, I think we can hand this session back over to you. Thank you very much. Thank you.
It's a big round of applause. Both the panelists and yourselves, you have tried. In our language, you have tried. We're going to round up. We would like to take a picture with them. So if the sponsors are still around, please come forward. We'd love to take pictures with you. Is there any other sponsors still around? Okay. Always forget I'm also. And then please note, some of you are in the room. You're not yet HFN members. I will join. Thank you. So to join as an HFN member, we'd like you to come in as your corporate organization. Ikwama is here. Our executive secretary is also here, Pharmacist Ayode Gioni. Ikwama, please let everybody see you. If you have enjoyed this forum, this policy dialogue, we have many more such benefits. The power that HFN has, this aggregating power, is at your disposal. Last time we were at NAFDAC. Prior to that, we were at the Comptroller General. We have a lot of work to do to get our healthcare system at the right level. Please join HFN. That helps us to do more of this work. Also, we would love you to sponsor our events. We cherish our sponsors. So please be a sponsor. Don't let us come and drag it from you. Initiate the conversation with us when we have events like this, and we will honor our sponsors. We cherish you. We appreciate you. I'll call finally the Financial Secretary for HFN, Dr. Olusegun Ebitami, to come and give us a vote of thanks. We will send you the presentations if you registered. We will send you the videos, we'll send you links, but please go on our social media handles. You'll begin to see snippets of all of the conversations from morning up until now. I hand over to Dr. Shegun.
Good evening, everybody. It's my pleasure to thank everybody that has made this a success, from our distinguished panelists and participants, the organizers, the sponsors, the Honorable Minister of State, and they make this an annual event, and we hope we'll see everybody at the next dialogue. Thank you, everybody, and have a safe trip.